copy. All right, so thank you for joining. Please comment in the comment section. This is your mentor, Dr. Shahriar. We are going to have this session. I've been a tutor since last 8 years, and if we just count the 2024 till the March result, there was like 1,290 doctor passed with nearly 92-93% of success rate. We also do help candidates while growing, supporting during exams or even after exam, by making seminars, and in many ways we try to help. I hope so. All the best to all the upcoming candidates. I hope so there will be a great result, those of you who are joining. And we'll be also asking at certain point that, what is the time for your exam and right time for the exam, and that we'll be talking about those parts as well. Great. All right. So great. I mean, we can see from a lot of countries, nearly 30 countries, I think people are joining today, we can see. And yeah, so here we go. I mean, let's go and have some regarding recall session. We'll be doing some April because April was the very latest, and we were supposed to do February, but I think we'll be going with the April recalls actually, because April was the very latest one actually. All right, people are still joining, so thank you so much. And maybe you can spend a 1 minute more. Please let me know in the comment section at what month you are planning for your exam, so that we have an idea and give you little suggestion before we start actually. So please let me know in which month you are actually thinking or planning for the exam actually. So I can see a lot candidates in July, August, a lot. Some I can see October, September, October, November, but I think looks more like a June, July is winning right now. Yeah, so that's the thing. Yeah, so this is that recall course we are studying from the 15th of April till 30th June. Then there will be another recall batch, which we will start, I think, in the month of August, somewhere in August or September. I think, we'll be having another um, recall course actually. Right? Great. So that's the plan actually. I mean, recall courses usually conducted for like a 2.5 months and 3 months actually. Can we join batch midway after this? I think if there's another batch in August, you can join, or you can even join now, because we have great recording policy in the recall batches. So you can join it now or even later. You'll have a little bit better recording policy in the recall. So this second. All right, I'm just back actually. So let me give you quickly demonstration. We'll be also talking about more things about the in terms of the taking the months actually. What I personally recommend, since you guys joined, so I'll give you a tip here that try avoid, in my experience, try avoid the month of June and the February. I mean, so far that's the update. Um, so try avoid the June and the February, which usually I recommend it actually. So avoiding June, because June was last 2-3 years, there was some new harsh questions were there. So I didn't much recommend the June. So from July it's onwards is fine actually. By the end of the year, it goes actually because there is more participation by the end of the year. So that is one of the reason. So more participation means during exam time, we can help you more. You must be knowing we also have exam support group actually. Okay, like for our exam candidates, you can ask the past candidates. We also support them, during the exam. So we called it a support group. So support group we made on the first day of that particular month. Say if there is a July candidate, so 1st of July we'll make a group for them, and say example if July exams are like 8 to 13, so during that time we'll try to support them. So if you try to take the exam date a little late, that will be better. In that case actually we can help you more in that case actually. Okay, so that's the strategy what we do. Yeah, so that's the thing actually. I'm just giving an example. I think it's like nearly, I think 16th it will start, 15th, 16th, I think the July exam will start. I'm just giving an example. So first day of the month we make that group, and during the exam we try to help them. Yeah, so that's one of our specialties since we are the first one to doing. Now I think many people also try copy it, but that's okay actually. So that's how we try to help. And if you are with our batches, I think there is no additional charge for the support groups actually. So that will be always with you actually, without any charges and the things actually, because anyway, so that's some of the things. So April 2024 recall we're going to do, and there's few things about the recall course actually. I mean, we do have a, please note, we do have, if anyone is very new, like is like new means of course not like not new in MBBS. I mean, of course, a doctor who is starting AMC preparation. That's why new I'm meaning. If someone is new or beginner in AMC, so we have a full 5 months of course actually for them. In that one, we have theory, we have recall, and this that. In the recall batch courses, it's a little bit more advanced. So either someone already prepared or self preparation, course preparation, whatever. People nowadays don't want to take chances, so people also do more practice nowadays. People also practice by a study group less. People want more ready-made things, so that's why these recall courses are separately created actually. Otherwise, these 5 months would have been enough actually for the guidance. So nowadays people wants more ready-made cake, more dessert, more pastries and things. So that's why the things. Our next 5 months batch, like just a little bit of information. Our next 5 months course is going to start from the 15th of May, and next recall course is also going to start somewhere in the month of August, September, perhaps. Actually, August is the more chances actually. Now, coming to this one, about this particular batch in recall course, we'll have weekly Friday and Monday classes. Then these are the time. Must attend live. After class record would be given. Previous 5 years record would be also given. Use laptop and headphone. Use it for the better view. Try not to use iPhone, iPad, mobile, Android, this thing for the classes. Imagine you're going for a big movie. Of course, you don't want to see the movie in the mobile. You want to see it in a big theater. That's why the laptop is recommended. Okay. Just want to like check with all the doctors. Is my video and audio is okay? Just please comment in the comment section. I just want you to know that if everything is working perfectly actually. Okay, sometimes we use the word, I mean, as like the army, we call it loud and clear actually. Okay, all right, we call it loud and clear actually. Yes, great. Okay, fantastic. Now, if we talk about the routine of the spatial recall batch, actually, this is how the routine looks like. So I'll be just zooming this part actually, like this is how it's looking like Friday, Monday, and you can see starting from 2000, so the 24, so 24 May, then there is a 24. So till, because this batch is till the June, so we'll be also covering the June. And as you all can see, so this slide 2000, so nearly like a 1 year of live we'll be conducting. We'll add you into the drive, and even if you have an exam in November, we'll keep getting some support through the drive actually. Okay, so this is like the little offer for this batch. If anyone is joining this particular batch actually, because most are targeting by end of this year, so even joining the middle, so you'll be getting coverage till the end of the year. So even if you want to join, you can join now, or otherwise you can join the August September batch. Great. Yeah, so this is like a special, some of the bonus pre-recorded, which will be also given support, and some of the big mocks computerized. Must attend some of our big mocks, um, because I use very authentic questions actually. Because a lot of people, they do what, they just copy something from the question banks and they put it as a computerized. So that actually is not a very good judgment always actually. So in order to have computerized one, it should be the nearest um, reliable exam questions actually, which is very, very important. All right. Great. So these are some of the things. And guys, if you have a batch related inquiries, please inbox me. It would be better actually. Okay. Because we are now in a live class. So I can't answer much related to course right now. Okay. Or after the class, we can do it actually. Yeah. Great. So please leave a message in my inbox in the Facebook Messenger. Now let's focus on the classes. So this is the routine, by the way, guys. This is the routine. This batch, I mean, for whom? This batch is for targeting mostly, say, um, July, June, July. June, we are not recommending much, but even June people can join. So June, July, August, September people can also join. And also the October, November can join because eventually you're getting the file support in any way. But if you're specifically having exam in November or October, maybe you can join this August batch as well. Actually, just a small recommendation, you can join the August batch. In that case, if you already know you have a exam in October, November, and you are already studying in our 5 months course on some other where, so in that case you can join a little later. Okay, is it loud and clear? I mean, one more time I'm asking, is it loud and clear, everyone? Like, about the syllabus, it is clear. So we are doing 1 year of life, you can see 2023. So from 1 May to 2024 June, we are covering. So like a 1 year plus we are covering, including some of the high topics, including some of the very big mocks. So in the middle one mock, in the end of mock, and the mocks will be based on the new questions. Actually, mocks will be based on the new questions actually, so it would be exactly identical to the main exams actually. All right, so this is something important. This is how the course details: weekly 2 classes, Friday, Monday. I think it's already nearly 5 year, actually 5 years now this we are giving. So from 2020, 21, 22, I miss, sorry, 22, 23 and 24 actually. All right, so a lot are given demonstrating the course. Let me take a few seconds. Let me take away the screen just to demonstrate how the notes section looks like for a recall batch. Okay, just in a 15-second, the screen will come in front of you. Please confirm me if you can see that one. All right, guys, if you have questions like how much is the course, when I should join, this type of question, please inbox me in my Facebook. Okay, so that's the thing. Okay, great. Now here is the thing, my dear doctors, because we are already going to have a class actually. So it's like some people might be offended if I start giving the course information and price information now. All right, so this is the thing. Great. Now this is how it looks like. Okay, this is how it looks like. Now, what's the strategy here, actually? I mean, we already mentioned, uh, I think we already mentioned like what we are going to do, right? So these are the class requirements, some of the exam tips. Okay, we'll be coming to that one. This is the schedule, right? This is our schedule. Now, if this is the schedule, what should be your strategy? If you join this batch, what should be your plan and strategy? Of course, 1 year or 1 year plus live classes will be taking in any way. So that you will be solving with us in any way, correct? Everyone agreed? So this is one of the part which eventually you will be covering with us. Is it clear? So your strategy should be, the folder I shown you earlier. Where is that? Yeah. So the folder I shown you earlier, you can target from the 2022, right? How mock will be taken by computerized mock? Small mock, large mock, lot of type of mocks are there. So there'll be computerized mock. Okay. Uh, please focus what I'm saying right now. Yeah, some people might get distracted because of your questions. So we'll be having a question answer session at the end. Okay. Please hold your question for some time. So you should start from 2022 because 2024-23, somewhere we are doing live in any way. Correct? So you can start from the 2022 and go backwards 2021, 2020, depends on if you get time. If you enter in any folder, say if you click the 2024 folder, this is how it will look like, right? Now, even if you go to any of the folders, like there'll be files, there'll be videos. So every folder may kind of look like the same. As a videos to files, an individual file has like a 50 questions, some cases 60, some cases it can be 40. These are the things are. So every folder is kind of like that, which I'm showing you right now. Right? So this is how the things are given, and we give this access to this whole 2024. So even if you join this one, you'll get the access of this one, and whole 2024 you'll have access to this. Like example, if we show you 2023, again similar folder like this. If I just click any one of them, yeah. So this is how it looks like actually. Any file folder, if you click, this all looks like this: video, 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 file. If I click any one of the file, let's click one of the file. Let's see how it looks like. I'm just picking randomly. Yes. So this is how it looks like. I just clicked one of the files. So this is how it looks like. So when you enter, you can also just, it will come to you like this. So click the slideshow and very easily you can study. Now, while you're studying, you can sometimes also study from your mobile device. You can also study from your laptop device, iPad as well. Yeah, but during live classes, we'd recommend you to use the laptop device, more recommended. Laptop and similar headphone, which I'm using, it's more recommended. So this is one of the just file I clicked just to show you a little demonstration. Okay, so any file folder, if you click, it will look more like this actually. Let me click another one, another file. Yeah, so yeah, that's how the things are. So showing that this is how things looks like. So question, answer, reference, question, answer, reference, question, answer, reference. This is how the things are given. All right, guys, if you want to know more about course, please inbox me by Facebook messages. I'm not gonna answer right now because we're going for a class right now very shortly. Okay, these are the things. People will find me in any way, so don't worry. Okay. So these are the things. Again, come back to the main menu. Sometimes we call it main menu. So main menu looks like this. So you can start from 2023, 22 perhaps, because 2024, 23 we're going to do in the live class in any way. And you can start from 2023 or 22 and can go backward by keep finishing. See, there are individual, not only file, there are videos as well. File video like that. Individual, this video is like 2.5 hours to 3 hours. So it takes a lot of time. So the more early you can join any batch, it's more better in terms. MC exam, in my opinion, I'm probably been the most experienced tutor. I mean, right now, still taking classes actually. Many, they take classes and at certain point they quit and so since been following, so MC exam has changed a lot in coming days actually. Yeah. So that's the thing. Video demonstration. I think video demonstration, we are going to take a class for you. Okay. Or otherwise in my YouTube, you'll find many, my dear. The classes actually. All right. So don't worry. Actually, that's a funny question. Video demonstration. You're already inside video and we're going to have a video class right now. Okay. So I found this question funny. Okay. Um, all right. Now coming to the main menu again. Uh, this one is our notes actually. So if I click the notes, so every system, there are notes that is present. Even many question bank, they sell question bank in 200, 300. I mean, if you join a course, our course, this all things will come to you. Also, we'll provide you a question bank separately. So note is a separate thing. These notes are to the point for the exam. Okay. So these notes are to the point for the exam actually. Yeah. So that'll be useful for you if you join, like individual, this particular things would be very, very useful for you actually. All right, great. All right. uh Other than that, there are sometimes 1 2 bonus classes we take. We also include them here, some of the bonus things. How to use the materials, how to access files. So here is a demonstration given. Some of the smaller mocks are given here. You can also get access with them easily. Some lot of small mocks are given, and the big mocks are will be taking computerized actually, not by in this method actually. Okay, there'll be links given, and with that link you'll be taking computerized exam, and you'll get result immediately. That's all the things. uh, if you join this current batch, the access up to end of 2024. Okay, I hope that helps. All right, guys. I mean, please ask me question later. I mean, I'm right now in the demonstration mode actually. Great. Or you can inbox me, leaving a question. We'll get back to you. Or my team is already active. You can also inbox them. They can answer you back if you need anything. All right. I hope so far things are loud and clear, which I'm trying to demonstrate. Yeah. So this is how the recall clause looks like. We're going to have a class right now. Don't forget that. Someone is asking, how can you demonstrate video? We're going to demonstrate you the video because I'm going to take the class live now. It will be similar the others as well, actually. So here is the thing, uh, informations, and demonstrations done, class requirement, some of the small exam tips. Yeah, should study theory properly. I mean, if you haven't studied theory properly, at least you can check our SMA notes for the theory. But if you're extremely beginner, there's a 5 months course. Then question bank, then study group, forum. Nowadays, exam support is also important, which we also include. All right. And uh, before getting into the final, I want to add something. How things are tested in MC part 1 exam. All right. Now, thing is here, they will give you a question. We'll see a lot of questions today. And into those questions, they will show you, like, say, they'll give you a scenario like a 55-year male. Okay, try to give me a diagnosis, guys. 55-year male comes with a sudden severe central chest pain and which is radiating through the person's jaw and arm, and the person having pre-existing heart disease. If you take history, his family is also having similar heart disease, and his father died of heart disease at the age of 50. Okay. ECG showing ST elevation. Now, what is your diagnosis? I hope you can answer quickly. So what is this? So this is nothing but a ST elevated MI. Some cases ECG will be also given. I repeat, some cases ECG will be also given. Now this is, they are asking what is the diagnosis. They'll give you MI, pericarditis, angina. They'll give you Dressler syndrome. They'll give you pulmonary embolism. Your diagnosis is MI in this case. Why not HOCM? In HOCM cases, the father will be dead is even more early. That's a good DD, but that's not the thing. All right. So that's the thing. Quick question. In HOCM, are you getting ST elevation? Quick question. In HOCM, are you getting ST elevation? No, it's mostly, stimulation is confined for uh, this MI pericarditis cases. So that's why it is not HOCM actually. Okay. Rather than echo finding will be given. Okay. In HOCM cases, sudden death noticed or sudden dizziness, suddenly unconscious. Actually, this will be the features. Okay. So are you clear like what I mean by diagnostic question? Is it clear, everyone? What we mean by diagnostic question? Everyone clear? Please comment in the comment section. This is question number 1. This is a diagnostic question. Now, in the same question, let me tell you, after that 55-year person having chest pain, this, that, and all this thing. Now they're asking, um, what is the next step? Okay, what is the initial investigation? If they ask you what is, I mean, not giving the ST elevation and asking this thing, so the ST elevation. Now they might mention ECG finding and they are asking what's next. So they might be asking initial, next, or best. In that case, your answer would be troponin, right? It's like most appropriate. Like, in this case, what is the most appropriate? What is the next most appropriate? You go for troponin I. Troponin I. Some cases they might also ask you another famous question. Just even this month we also saw, even in the month of February 2024, we also saw that question. Many times I saw this question coming in MC exam. That is, in the early stage of chest pain, the person is having normal ECG, normal troponin, normal ECG, normal troponin. What do you want to do? Release the patient, discharge the patient, will observe him, or will repeat the ECG, repeat the troponin. I'll give it a lot of options. Repeat the troponin, repeat the ECG, discharge, send him home, or observe him for 24 hours actually. So a lot of options are given. The answer here, according to Australian guideline, you have to give an answer. The answer is a repeat the troponin, repeat the troponin. Now, is it clear to everyone? So this is also like a better approach, like a best approach. You are given a lot of option, like a something like a discharge option was also there, also investigation option. So this is the best approach in this case. So that was the question about the best approach. Did you understand what do you mean by this best approach? So this was the best approach, like repeating troponin, not sending home at this point. So sometimes the investigation, also some of the management things are mixed up. So that is that time they will ask you what is the best approach that time. In terms of the management, let's come with the management. A case where, please understand the case. A person whose age is nearly 32, person is obese, person sometimes having, whenever they eat nighttime, they get a lot of heartburn. So they complain, I need 2 pillow. I need two pillow, I need two pillow to sleep. Otherwise, I feel a lot of discomfort and I feel a lot of irritation in my. Um, and there's another word which is very popular in MC exam. The word is bloating. Okay, so irritation. Uh, Symptom feels like somewhere like a chest pain. So what is this? Is it a chest problem or is that is something else? Now, I think I can see many of you are answering. This is a ZERD, gastroesophageal reflux disease. Now, in this case, they might ask you, what's next? We know esophageal cases, the initial is a barium. Do you like to go for an ECG here? Or do you like to go for a PPI for a month? What do you think in this case? Now, unless significant chest pain, now here's the thing. Those of you are thinking about the ECG, unless significant chest pain, you don't need the ECG. My question is, what you like to do initially in this case? The answer is a trial PPI for 1 month, trial proton pump inhibitor for 1 month. I hope that's clear to all of you, right? We don't go for barium, do we? I mean, we don't go for a barium. Anyone, otherwise, a lot of people will require barium and this, and it itself also has some cases. If you do endoscopy, barium, they also contain risk. Actually, we don't go for always investigations and this that, right? So this is the thing. So they will ask you things, and if they ask you about the management of ZRD, what will be the initial management? What would be the initial management? So initial management would be, in this case, a trial PPI, 20 milligram. Now, what would be the best? Patient came to you again, telling, whatever you gave, it's not working for me. Whatever you gave, it's not working for me. You have given 20 milligram. Now, would you like to change it, everything, the plan? Now, here is a very popular thing. You double up the dose. We call it double up. So like a 7 up, double up. Okay. So double up the dose. So we go for a 40. Have you seen professors are giving 40 millimeter of proton pump inhibitor, pantoprazole? Have you seen that one? Or maybe many of you also use. Maybe many of you also take sometimes. Yeah. So if you have obesity and you are sometimes required 40, maybe my dear, you are also having some ZAD. I guess so. All right. So that's the thing. So only long-term plan is the weight loss, right? So most appropriate long-term plan. This is another type of question. Most appropriate long-term management plan is a weight loss. Okay. So you will be also asking question in that way. This is how the AMC question been asked. Is it clear, everyone? I mean, am I going too fast? Please let me know in the comment section. If I'm going fast, is my speed is okay. All right. All right, everything is clear. I mean, with the years of experience, I feel like this is a sustained speed actually. Okay. Yeah. Okay, great. I work with also teachers actually. Like I used to work with the teachers training as well. I used to also train teachers. So I believe my speed hopefully is okay. All right, clear. But still let me know because it's early stage of the classes. For some people, it might be a little speedy in these cases. Okay. Next one is a statement type of question. Next one is a statement type of question. I will show you a statement type of question today while we'll proceed with the classes. So you have to be in the class to know what do we mean by statement type of question. Now, one information about a statement type of question is they will test your depth of knowledge. MC not only judge your clinical virginity, but also test your depth some cases with some questions. Now, they will give you questions like that. Say the same ZRD question, if they're giving big liners, like ZRD is the most commonest GIT problem in young people. ZRD initially treatment does not require. ZRD can lead to cancer. Now they're testing the information and they will be asking the question, which of the following is correct or which of the following is incorrect. Do you understand now what do you mean by statement type of question? But I will give you example. As long as the class progresses, there will be things like that. So which one is correct? Which one is incorrect? I believe the which one is incorrect one is even more difficult. What do you think, guys? The one which is correct to difficult to pick up, or one that is incorrect is difficult to pick up? The one that is incorrect is more difficult to pick up actually from the. But here is the tip. Please check carefully in the exam because you'll be in a lot of rush. So please check whether they ask for the correct one or whether they ask for the incorrect one actually, because you'll be in a lot of rush in the main exam. Okay. Another tip here, always check if it's a treatment type of question. If it's a treatment type of question, always check is the person is allergic to any medication, right? Like, this is a cellulitis. Okay, I'm going to give penicillin. But somewhere in the question, they have written allergic to penicillin and you miss that one. So certainly you will miss the whole question because now your treatment would be something else, not penicillin for sure, or not flucloxacillin for sure. So always check. This is another tip. Many miss question. Many they know the answer, but it's presence of your mind actually. And the MC examiner. I often say this MC examiners. They have a lot of hookums actually. All the time, lot of ohms, and in the month of February and June they have the hookum, I think, increases. And yeah, maybe also chameleon, they change color, they change question, and they also have a lot of itching sometimes. So as also fun part. Yeah. So I have respect for them actually, but they keep changing question all the time actually. All right. Anyways, now coming to the another one is a data analytical type of question, which is more like a biostat type of question, which we already have a folder in our recall batch, or those are regular batch in the video channel. We have the information and the video regarding the biostat actually. Okay, so we will brief you on that one, like how to tackle the biostat. We have two biostat video, and we also take biostat classes actually, especially in the recall classes actually, just to cover up a lot of things. Next coming is a thing is a risk analysis. Now, let me give you an example. Guys, are you ready? I mean, are you following me? Are you bored, or I should start the questions now actually? Let me know. I mean, if you are bored already, and then I can straight away go to the question. Okay. All right. I'm trying to give example actually. All right. Yeah. So, yeah, there's a lot of new people actually. I mean, so they should know what are the different pattern of the question. Example, let's say, uh, which one is the biggest risk? If someone has spotted uh, a black mole in the face, and they're asking what is the biggest risk. Now, uh, previous melanoma history, uh, previous dysplastic change, family history of melanoma, previous history of sunburn. Okay, I'll give you four options. Previous history of sunburn, previous history of melanoma. Um, and there's another one called olive man. Olive man is also means sunburn actually. So please mark this word, olive man. Okay, it means sunburn history or dysplastic changes actually. All right. So which one do you think is the bigger risk? Answer: the previous history of melanoma is the bigger risk actually. Previous history of melanoma is the bigger risk factor for melanoma. So this is a risk related question. So they will be giving you not of relevant questions like that, right? Someone asked what's after that. Previous history of melanoma. After that, uh, thing would be, any guesses, guys? Before I giving the answer, previous history of melanoma. After that, any? What do you think? Before family history, something else. Dysplastic changes. Dysplastic changes. All right. Now, there's a word called sometimes dysplastic navy. So if more number of dysplastic navy, all right. So it's a more probability chance. More dysplastic navy, more chances. Clear, everyone? Like there was a line, more than 6 dysplastic navy, the patient categorized as a high risk. More than 6 dysplastic navy is categorized as a high risk. So I'll teach you someday, like a differentiation between high risk melanoma, intermediate risk melanoma, low risk melanoma. So high risk is a previous history of melanoma and 6 dysplastic navy. Yeah, so that's the thing. Clear, everyone? So these are the question related to risk assessment, risk related question. So this can come in many form. Okay. Now, some cases they'll ask you specific symptom. Now, stomach cancer, which is getting rare nowadays, but they can definitely ask you a question. What is the most specific symptom of stomach cancer. Most specific symptom for stomach cancer. If I ask you, like abdominal pain, weight loss, then appetite change, right? Bowel change. Which one do you think is the specific? Yeah. So answer is a weight loss. Answer is a weight loss, not the dysphagia, my dear. Okay, great. Oh, great. Moving forward, and yes, I mean, we certainly have covered, and let's go and start. Are you guys ready? Please bring some positive energy, guys. Are you guys ready? Yes, let's go and start. All right. Okay, I'll turn off myself here and let's go and start. 16-year boy presents with a routine checkup and his weight and BMI are recorded, found to be 95 percentile of his age. Accordingly noted that both parents are obese. This is good news for us, but not certainly good news for the parents. Most appropriate advice to give the patient based on the information. Now you have 5 options and have to give in one answer. You have 10 seconds to answer this one. Come on, guys. It's okay. Take your time. Take your time. Yes. Always check if there is a better option which covers everything. Now, certainly, you can also do this low calorie exercise program. But if you choose the C, diet control and exercise, that covers everything, isn't it? Right? I mean, be technically correct, be technically correct. But C covers everything. All right. All right. So here is the thing. So right answer is a C. Right answer is a C, diet control and the exercise. Actually, surgery we're not recommending actually at this one. Like that surgery actually, sorry for this spelling mistake. It's obesity relevant surgery, bariatric surgery, So that's the thing. So it's not recommended, right? I mean, who recommends surgery in the first step? Actually, they will tell, oh, this is the doctor, who loves to take all the money, right? Okay. Okay. So we don't recommend the surgery in first hand, actually. In any ways, in our country, we doctors are already, you know, don't have that good impression. Do you? I mean, I'm from Bangladesh, even though I live outside, but do we really have a very good impression as a doctor? I mean, or you have been blamed, that, oh, doctors means, taking our money actually. So we have been blamed all the time. Yeah. So anyways, also social security and many things that leads our doctors to migrate to many other foreign countries. Many also I saw wants to migrate because they want security for their children. Okay, many people may have many things. Let's move forward to the next question. Which of the following laboratory finding is characteristic of syndrome of inappropriate ADH? Syndrome of inappropriate ADH. Please start guessing. SIADH means what? High ADH. SIADH means what? It's a high ADH. Now, what is the function of ADH? Increase absorption of water, isn't it? So water reabsorption, isn't it? Water reabsorption, actually. So this hyponatremia happens in blood. So from the renal tubule, the water is reabsorbed into the blood, correct? And there is dilutional hyponatremia. If I use a word, seizure, is that incorrect in SIADH? Please think. Please think. Yeah. So hyponatremia and low serum osmolarity because the serum is going to be diluted, whereas urine is going to be more. Can I also say the urine is going to be more concentrated? Urine osmolarity would be high. Would you agree with me? Because urine become concentrated. Water is going from the urine, water is going into the blood. So urine osmolarity higher, serum osmolarity lower, and hyponatremia. Agreed? So D is correct answer. With that note, D is correct answer. I think we don't have to go for the other explanation. I think you already understood. But still, Checking our SMA note. This is already SIADH is one of our note in the note section. So excess ADH functions to water reabsorption from the distal convoluted tubule. I hope you remember where was the distal convoluted tubule. Yeah, we can call it dilutional hyponatremia. Definitely, my dear. Okay, so concentration, urine concentrator. So increase urine osmolarity. Can I write like this? Urine osmolarity is more than serum osmolarity. Can I write like that? Would you be agreed with me? Yes, I hope so. Yes. So urine osmolarity is higher than serum osmolarity. Okay. Diluted blood, hyponatremia. They can also have seizure some cases. Next question. Patient presents with a spinning sensation, which some of you are already having right now because your MC exam is coming, right? All right. No, anyways, horizontal diplopia and normal hearing. The patient finds difficult to maintain a standing position, prefers to be in supine position. Okay, so what is your likely? So see, this is a diagnostic question, which we are talking about one of the type. This is a diagnostic question. Start your answer, give the answer in 10 seconds. A lot of points have been given. Yeah, this is the first class for our recall course actually. Yeah, I think invited our theory batch. This is a class specific for our recall batch doctors actually. Okay, no problem. It's a new one. It's April 2024. Yes. Great. Now coming to this one. Okay, we have picked up vestibular neuritis. We have picked up vestibular neuritis. Okay. Now, many of you are thinking this one as a BPPV. Many thinking this thing as a BPPV. Let me show you a chart first of all. Okay. Are you ready for this chart? Okay. Certainly it is a yes. And also I'd like to show you something particular. A question. I mean, often there's a very nice handbook question. I often see that question for ENT. Okay, very useful. One question, let me tell you, this is a handbook question. Okay, 3.029. If you want to document that number, please go for it. 3.029. I've highlighted a line, no association, deafness, tinnitus. I'll come back to here. This one is a bit learning. Now, so always check the age. Okay, like Meniere's disease, I'm not expecting 25 years. So when I see question, I quickly understood, which I can exclude. Meniere's can't be 25. Any cancer can't be 25. Less likely. I mean, at least in MCQ exam, actually. 25% presents with acute history of intense vertigo on working imbalance affecting left side, pain in the left ear, sensation of environment rotating, like environment rotating, spinning, similar words, and giddiness, ataxia, and with vomiting. So because of spinning, people can have vomiting unless he lies completely still. It's not associated with deafness and the tinnitus. Okay. On examination, he has nystagmus with component to the left. Canned examination is otherwise normal. Caloric test showing vestibular function, reduced response on the left. Now, can you tell me in which case caloric test is positive? What do you think? Which case caloric test is positive? The answer is in vestibular neuritis, caloric test is positive. In other cases, it is not. Now, here is another line which you call the negative history. Someday you will go to the MC part 2 and you have to ask the patients also some negative history questions. Like, do you have his deafness? Do you have tinnitus separately? Now, this is important actually. No associated deafness or tinnitus. Now, how many condition is associated with deafness and the tinnitus? Quick question. BPPV associated with deafness or not? If we come back to this question, here it is mentioned normal hearing. It means what? It means no deafness. No deafness. Now, certainly we can rule out some option. Now we can see labyrinthitis. Labyrinthitis, does they have deafness? The answer is a yes. Sensorineural deafness. Now we can see Meniere's. Yes. Okay, then, but this one is a no. So this one still can be answered. And vestibular schwannoma, vestibular cancer, and certain other things. Now, if you come back to this question, I'm just putting this one as a learning for you. Can you cross this one? Can you cross this one? Yeah, certainly yes, because no deafness. Can we also cross this one? Because we have a normal hearing. Can you also cross this one? Acoustic neuroma also have deafness, hearing loss. So three of them very quickly excluded just because of one point, that hearing loss or deafness, right? So let's check. This is a very practical question. I love that handbook question, and so as that one. This is the trick. So quickly rule out that one. So your confusion will be mostly between two. Now coming to this particular point, many of you answered this one A, many of you answered this one C. Taking this one, difficult to maintain a standing position and prefers to be in supine position. Now my quick question, if you ever have seen a BPPV patient, does they prefer supine position always? It's not really. They rather will complain if they sleep, if they turn head, even sleeping, still there is a spinning. Okay, you must be knowing about that test name as well, like the Hall pipe test, or there's an Epili maneuver to correct it. So while even in sleeping position, the issue can happen. So prefers to be in supine position is a contradicting, right? Prefers to be in supine position, it is contradicting. If they would have been said, um, okay, traveling and this, that, more chances of spinning, and when they take rest, then it is less. Then I could have believed BPPV, but BPPV never prefers to be in supine position. Okay, that's one of the key thing. So perhaps this option is also out, because this is not a perfect question. This is a recall. So this is a perfect question. So this one looks more complete. So it's easy to answer, right? So it's a bit more easy to answer because they give you clinical virginity. They also give you a physical examination finding or laboratory finding. So it's more easy to pick up. So recalls are some cases more difficult because one or two lines are missing in the recall. So is it clear, everyone? We went by exclusion method. In MC exam, you will be needed a lot of exclusion method, right, everyone? So this is the method you need to use for many questions, exclusion method. Okay, one by one. Please remember here for the ENT that deafness and the tinnitus word would be very useful to differentiate at least two or three options, quickly rule out. And then you think between two, okay, between these two, which are the more relevant, is there any laboratory finding? Yeah, like that. Clear, everyone? Can we move to the next one? Yes, I'm just trying my best to teach you guys. I hope so that's best. All right. Next question. Patient presents with a limping and a swollen and a tender warm knee joint, but it is not erythematous. Child also has an upper respiratory infection. Now we have a history here. What is the most appropriate investigation in this case? Okay. Now let's find out what's going on here actually. Which one you'd like most appropriate? Always check this line as well, what they're asking. Most appropriate investigation. Okay. Now, in this case, some of you would be thinking as a A, some of you thinking as a B. Now, understand what they have asked. They asked for most appropriate. So ESR can ever be a most appropriate investigation. My quick question to all the doctors: can ESR ever be a possible like a most appropriate? It's never. It's a non-specific test actually. So those of you answered B, you have to be careful next time answering. I mean, most appropriate ever asked never can be an ESR. Okay, those are going for O tighter, at least that's okay. Yeah, but this CBC and ESR is never be, cannot be an most appropriate investigation. Clear, everyone? Okay, so there's another way to rule out questions. So there's a way to rule out things very quickly. Okay. So most appropriate investigation. Now, why we're thinking this condition as a septic arthritis? Now, what do you guys thinking? I'm thinking this thing as a septic arthritis. I'll tell my opinion. But are you guys also thinking this thing as a septic arthritis? Now, coming to this point, the kid has a limping. Now, with a limping kid, if you remember, there are certain conditions like a limp related in pediatrics. There is a chart, right? This is taken from John Mortag. DDH, transient synovitis, and pertussis. Transient and pertussis in the similar age group. Sleep capital femoral epiphysis 10 to 15 years. So often they will tell you adolescent age group, a obese kid. Nothing really mentioned like that to go for something like that. Thing remains is a septic arthritis actually. Some might be thinking as a transient synovitis. Why? Because there is an option given about upper respiratory tract infection. This is can be a contradicting point for transient synovitis. Okay, now let's come and see what are some of the points for transient synovitis. Now you can see a prodromal of upper respiratory tract infection. Okay, and unfortunately, age is not available in this recall. Limping and perhaps these particular 2 points are matching, right? These 2 points are matching. So certainly here our 2DD, like transient synovitis and septic arthritis. Now, how can we differentiate based on this question? Swollen, tender, warm knee. Now, is that a feature of transient synovitis? Knee joint. I mean, knee joint, they didn't mean joints, so means one joint. So swollen, tender, warm knee joint. Okay. Swollen, tender, warm knee joint. Now, there's a line in individual swollen, tender, warm. So the warm means increased temperature as well. Okay. So it is technically we have to think about septic arthritis until proven otherwise. Septic until proven otherwise. Then you will start thinking anything else. Like say if you delay the treatment, like a transient synovitis, you can delay a little treatment, it doesn't matter. But can you do that for septic arthritis? Can you delay the treatment for septic arthritis? You will be in serious trouble. And moreover, the patient will be in serious trouble. There can be joint damage, whole damage of the joint. And there can be sepsis as well, possibility. So question is coming, what is the first line of management of septic arthritis? Is it a arthrocentesis means joint fluid aspiration or giving an antibiotic first? There's another question often tested. Either this question comes or that question comes. Like, are you going for a transient synovitis, arthrocentesis, or are you going for antibiotic? Okay, I'll give you two options: arthrocentesis or antibiotic. Antibiotic. Which one would you like to prefer first in a case of septic arthritis? Please tell according to books, book reference. So answer is a arthrocentesis first according to many books. I can give you a reference of Oxford Handbook of Medicine. I can give you a reference of Davidson Medicine. Unfortunately, it was not clearly mentioned in John Murtagh, but I have got reference from two of the very good books, Oxford Handbook of Medicine and Davidson Medicine, followed by, it's not like antibiotic you're going to start after 1 day. It's not like that. Just after doing, you just take the sample of that one and immediately followed by an IV shot. And which antibiotic is preferred here? IV Fluclox. IV Fluclox, 2 gram to start with, guys. Very high dose, 2 gram, very high IV. I hope that's clear. That's clear. Yes. So suspicion of septic arthritis because of this particular key liners. Everyone clear? That warm I'm taking as a temperature. The warm thing I'm taking as a temperature here. So individual joint, pain, swelling, temperature raised, septic arthritis until proven otherwise, John Murtagh line. Coming to the next one. 25-year female with a mid-neck swelling. This is how the pictures are given. Moves with the swelling, moves with deglutition, protrusion of tongue. On examination, thyroglossal cyst is suspected. What is the most appropriate investigation confirming the diagnosis? Okay. Let me come and show my face. Otherwise, some people will start sleeping just to make sure that I'm also here. And, keeping eye on you guys. So don't try to sleep. Don't try to go to the bed. I'm also not going to the bed, guys. So I'm also sitting. So those of you are already um, trying to, sleep and with a mobile, their one step is towards the failing actually. Okay. So just make sure. And I can, do you know one thing? I can turn on people's video, even though Zoom, I know some tricks here. I can turn on your video. So don't be in unusual position. Sometimes it happens. Like, we open suspecting someone is, I see, I think if someone is eating, at least that's appreciated. I mean, serious about class and eating, not leaving the room. I found, I think 2 or 3 times in my career, I open, someone is sleeping totally. There's a famous joke in the Zoom. If teacher calls me, please, wake me up actually. So I hope so we don't have anyone like this, at least because here the pressure is high. It's not about a grade system. You have to appear in exam. So at least people are not sleeping for sure. Anyways, fun apart. 25 year, and these are the things. Let's go for the answer, guys. My eyes are on you. That's my saying actually. Okay. Now, first, before going to that investigation, what is your diagnosis here? Very important to know, understand what is the diagnosis. So it's a kid and moves with deglutition. I think it's already very clear. It's a suspected thyroglossal cyst, and if it's a thyroglossal cyst, uh, we should go for an ultrasound. Everyone clear? If it's a thyroglossal cyst, ultrasound is the most appropriate initial investigation confirming this is a thyroglossal cyst. It was easy peasy, I believe. Talking about mass. Okay, in Bangladesh, mass means what? This is how we tell mass. It means fish. And we're not talking about mass, we are talking about mass. Okay. Now, there's a lot of masses that comes in MC exam. Some of you might be knowing. Now, here is a thyroid mass. Can you tell about some other masses, which is very popular? Renal mass, very popular. Then there is a adrenal mass just sitting on the adrenal mass. Lung mass, lung cancer. Abdominal mass. What is abdominal mass means, guys? Triple A, abdominal aortic aneurysm. Ovarian mass. Ovarian mass. Salivary mass. Okay. Among them, you can take it as a writing. You will get at least one question for sure. From this 6 or 7, you will definitely get one question. 100%. So always comes. Maybe 2. If you're lucky, you'll get 2. Okay. So these are the mass questions. Okay. Next one. Patient presents with abdominal pain, swelling, vomiting. Later, patient develops bloody diarrhea. What is the causative microorganism? This question is a bit incomplete, I would say, because too limited. It's too broad. Abdominal pain. You can make 1,000 of diagnosis, nausea, vomiting with this option. Uh, one specific liner is a bloody diarrhea, which specifies few of the things like Giardia is probably out, right? Salmonella is probably out. Norovirus is out. Now remains because of the bloody diarrhea. This remains and this remains. Now nothing is mentioned. What is missing? Patient's age is mentioned. Is the patient is traveling? It is also mentioned. If the traveling is given after coming back, when it starts, that's also is this information is important for you? The incubation period, is it important for you? Like after coming back, when it is starting, 1 week, 2 week, 3 week, definitely very important. So for this type of question, age is important, travel history is important, which country they're going, and after coming back, when it is starting, that's also important. Would you guys mind if I try to talk something about the travel medicine before going into the answer for that one? Okay. It's usually not much discussed in MC in that way, but questions does come from that. So travel medicine, travel. All right. No, sorry about handwriting. Um, this one is a bit more like a travel question. So let me bring it again with a whiteboard just to clear that one for you. Okay. Is it okay if I spend 5 more minutes to give you idea about like 10 travel questions? Okay, sorry, let's do it from here. Okay. Number one, very popular question. Someone, I mean, unnecessarily people blame Thailand. Those are supposed to get STD can get STD from anywhere. Is that correct? Okay, that is true. Only Thailand is unfortunately too much blamed. Okay, whatever. Now coming back to that one, I mean, but as for exam purpose, we'll remember that actually, unless not. Like someone been recently to Thailand, young person being to the Thailand, and after going there, yeah, Cambodia sometimes also blamed. So being to Thailand, uh, coming back, the person is also having some fever, flu-like symptom, discharge. Yeah, I never heard Egypt for that actually. Okay, all right. Oh, sorry about that. So after coming with that one, this is possibility the person is having syphilis, gonorrhea, this, that things, depends on discharge, depends on ulcer, and this, that. STD related, we already have a note. You can check that one. So if after coming back, if there's a genital discharge, genital ulcer, this, that, it can be syphilis, it can be gonorrhea, it can be Haemophilus ducrei, it can be herpes as well. Okay. So these are the points to remember. These are the points to remember, guys. Okay. So for STDs actually. All right. For the STDs. In my opinion, any country, anywhere, unprotected sexual intercourse, anyone can get STDs. That's the thing. So most important thing is not actually the location. The most important thing is actually asking the patient, especially if someday will come to our MC2, you will see it's not the location, it's the question you have to ask actually. Are you like uh, performing any kind of sexual intercourse, unprotected sex? That's the main question actually. All right, so that's the thing. Next is a like a Iraq related a question came, or any desert area, this thing. Iraq related a tuberculosis question came actually. Okay, in past. So please keep it in mind that someone is an immigrant. He was in Iraq and then came and then having tuberculosis. We have also seen the similar tuberculosis question from the Asian countries like Bangladesh, India, Pakistan, and these countries. TB exists in most of these countries. Quick question is, tuberculosis is a common condition in Australia? Quick things to ask all the doctors: is tuberculosis is a common thing in Australia? No. That's one of the reason. Even while you're going to Australia, they will do only one or two tests. One of the tests would be doing a chest X-ray. While you go to the Australia, you'll see they'll ask you for chest X-ray. Okay. Yeah. Indonesia, I'm coming back. Don't worry, my dear. Yes. Yeah. TB exists in most of the Asian countries, right? TB somewhere exists in most of the Asian countries. That's the fact. But somewhere they will give you Iraq, India, Bangladesh, these things for those questions actually. All right. Developing country. Well said. Developing countries. Yes. Uh, there was another question with the Sudan and Somalia. Okay. Any guesses? Which disease, like not in disease, but which condition will came up after that? Somalia and the Sudanese baby. That's how they mention. So often we found. like a vitamin D. Vitamin D. With the Somalia one and some of the African countries, it was mentioned cystosomiasis. They will be presenting with a hematuria. Okay, they'll be presenting it. So Somalia and some of the African countries, it's been mentioned like a cystosomiasis actually. Just keep it in mind. Yeah, African countries. And Sudanese baby, and at the same time, some of the Middle East countries, it's a more prone to develop vitamin D. All right. So this is like the other things. I also asked, there's one of my doctor, he was from Sudan. I asked him this question, is it common vitamin D deficiency? And he said, yeah, it's quite a common vitamin D deficiency. So country-wise, it's a possibility. Country-wise, a possibility. Zimbabwe. See, particularly, I didn't study it about Zimbabwe, but I haven't seen much question, particularly names say about Zimbabwe. Okay, that's the thing. So I'm just telling you, those have been tested more in the exam. Now, coming to the Jakarta. Now, where is Jakarta? Any guesses, guys? Where is Jakarta? Last time I asked, someone said Jakarta is in Thailand. Is it true? No, it's in Indonesia, my dear. Then I asked that same person, actually, then where is Bali? That's in Indonesia. So people know about Bali very well, but don't know about Jakarta very well. That's weird. Anyways, now Jakarta is common and very popular in MC exam regarding the dengue or dengue, whatever you say for dengue. So this one is popular there. So someone recently traveled to the Indonesia. After coming back, he has a breakbone fever, right? And pain in the bone areas and this that, and pain in the first week after coming back. So it's more chances Sakarta. Clear? That's the thing. Not really about traveling always outside. I mean, inside Australia also Aborigine. Aborigine, they live in certain areas like Western Australia or some of the particular places, Alice Spring, and these are the things. So Aborigine can have which disease more common? Aborigine or the Torres Island, Aborigine and Torres Islander, they call it, right? So it's more common is a diarrhea, giardia, alcoholic, liver diseases, hepatitis conditions. Okay, so those are more common in Aboriginal. Uh, if you read the RSCGP Red Book or RSCGP guideline, you will see for a normal people, many guidelines started from 40 years, whereas many guidelines started from the age of 35 for Aborigine. You will find a difference. Okay, keep that one in mind. Okay. After coming back, traveling to say any places like can be Thailand, can be Indonesia, the person develops flu-like symptoms like a fever, high fever, fever with chill and rigor, with a chest, some of the chest pain, what you are expecting. So they expect pneumonia. So after traveling, it's quite a possibility the person can develop pneumonia, but they will be telling you it will be under 1 week. Is it clear, everyone? It will be under a week, they will tell you. Now, the same thing, if the person came again in a 1 week and a breakbone fever, it would be a dengue or dengue. If the person is telling that there is a development of fever 2 weeks after traveling, and some findings are bit like bit jaundice at the same time, what you are expecting in this case. So that's going more towards fever with chill and rigor, and maybe a little jaundice at the same time. It's a malaria now actually. So 2 weeks of incubation period is a more chances for malaria. Malaria. Okay. TB and also pertussis. Malaria, TB, pertussis after 2 weeks. Okay. But TB and the pertussis will have characteristics cough, especially pertussis cases. Characteristics cough. Pertussis cases are more common. They will be given child actually. So child not vaccinated went to Asian countries coming back. The pertussis means whooping cough. Clear? So whooping cough related, you will get a lot of questions. The separate section in the pediatrics often, the whooping cough. Clear, everyone? Pertussis. It's often called a 100 days cough, isn't it? Next, another thing, the patient after traveling to outside the Australia or maybe even inside the Australia, maybe they went to a lake. Have you noticed they love surfing a lot and they love to swim a lot? All the OZ, they love to swim a lot. One time I remember I was going through Melbourne to Adelaide, the Great Ocean Highway Road. And has anyone been to Great Ocean Highway Road? Fantastic road, right? Breathtaking. So I saw, 2, 3 are going, even very cold it was, but 2, 3 was going towards the sea actually with long boards because they love swimming all the time. So they're putting the wet jackets. And so that's the thing. Now, these people also go for camping a lot. Australia is full of camping. Uh, Western Australia is very popular. So there are some lakes too. So stagnant water and this, that. So they can develop subconjunctival hemorrhage. I mean, whole red eye. And that's called yeah. So there's a possibility of Legionella, leptospirosis. These are the possibilities in that case. Legionella, leptospirosis, these are the possibilities. Clear, everyone? So please remember this. And I like to go to the next slide. But before that, I like to give you uh, 3 slides as a screenshot you can take. Maybe that's not included in that slide. Incubation period. Yes, here it is. So please take a screenshot of this one. So this is the first one regarding the short intubation period with staph and bacillus cereus. Okay, popular in the exam. Like just after eating, started vomiting, nausea. That is staph and bacillus. So this chart is important for you. Clear? Okay, 5 more seconds. 2 more seconds. Next one. You see, less than 2 weeks. These cases. Yeah, even though malaria name is given, some specific of malaria can possible below 2 weeks, but the malaria is mostly after 2 weeks things actually. Okay, that's why the name is here. Don't get confused because of that. But in exam, mostly it will come as a after 2 weeks. Okay, so less than 2 weeks. So malaria, chikungunya, dengue, and please take a screenshot. This is in general actually. This chart was from the Davidson's medicine. 2 seconds more. I hope done. Next one. Last but not the least, this one. 5 seconds. So on the basis of that, one question is 100%. You are getting one question 100% from travel medicine. No? So they say 2 to 6 weeks is malaria, TB, leptospirosis. Yeah, these are the things. Q fever, trypanosoma. Trypanosoma comes as a heart condition. Also, African countries more common. Anyways, I hope clear. Please let me know was this discussion was helpful. Coming back to this question we decided as E. coli. Sometimes during travel, probably the missing puzzle is person is already uh, were traveling to some other country and later develops bloody diarrhea. Uh, Later develops bloody diarrhea while traveling. So we have seen questions like that. I'm just assuming this is the question. On the basis of that, probably this is a chances Escherichia coli or E. coli. There's so many missing puzzle in this question. So that's why I took you guys to the travel medicine section and try to guide you guys a little bit. Was this discussion was helpful? Sometimes should I discuss side things like that? Let me know, the new doctors, in the comment doctor section actually. I mean, side informations, are they helpful or not? Please let me know. But it takes sometimes some time actually. So some of you might get bored in that case. But I have to balance things, right? I mean, yes, okay. So E. coli, known to having bloody diarrhea, abdominal pain, then nausea, vomiting. It's more common cause of blood-borne, often associated with contaminated meat, unpasteurized dairy product. Like this question is too much, incomplete. They will give you at least a history of eating something, a patient's age is missing, travel history is missing. When coming back from travel, it's also missing. Now, can you correlate? Like, is it a complete question or a missing question? Or yes. Wait to the next one. Someone is moving in the road actually by opening. Okay. Child is observed to prefer spending time alone, exhibits a preference for lining up toys. Keyword, not a very good sign always. Demonstrate good eye contact. There's some improvement noted with methyl, some not good enough. Now, can you tell me methylphenidate is a drug for what? It is a drug for ADHD, right? Too much hyperexcited people like a ADHD, correct? Now, this one, is it going towards ADHD? Is it going towards autism? The answer, this one is going more towards lining up the toys, demonstrate good eye contact. Now, this line may contradict because typical autism is a very big term. Autism has a spectrum. Actually, there's a many condition. There can be many level of IQ. So many autism kids, they also do eye contact. So it's not an uncommon thing. So the level of things could be there. So it can be, but lining up toys, this is a keyword. Yeah. So this is a one of the early feature and not improved with methylphenidate. So this is somewhere indicating autism. Clear, everyone? Normally, we are expecting not having good eye contact. That means it's going towards more severe. So those who are a bit more moderate to severe, they don't do eye contact. Those are having the mild one, they do eye contact, right? IQ has also a lot of levels, right? Yes. Have you ever taken IQ test, guys? Have you ever taken an IQ test, guys, in your life? Yeah, no. They do someday, maybe, yeah, get to know. So your main IQ test would be in the MC exam. All right. So your main IQ test would be in MCQ exam. Okay. Fun apart. I'm just joking, guys, actually. Yeah. If you pass, means you have good IQ. If you fail, means you probably need more treatment. Anyways, just fun apart, guys. Like, don't take the word seriously. Okay. Next one. Okay, let's do 5 quick questions. 18 months girl presents to a general practitioner. Mother expresses concern about frequent fall. Okay, this is the chief complaint. On examination, child demonstrated a tiptoe walking, mild impairment of dorsiflexion. However, other developmental milestone normal. Key line. What is the most appropriate management? All milestones are normal here. So perhaps this condition is going towards C, considering this thing as a normal. Most appropriate initial. The child symptoms relatively smile, nothing much here. All other developmental milestones are normal. So just reassure in this case. Yeah. What are the other else option? Neurological. I don't see any neurological concern here. No focal neurological deficit. Not a single focal neurological deficit. Only thing was a frequent fall, but I'm expecting focal deficit means sensory, motor, complexities. Those are not there. So you can just reassure in that case. Remember one thing, uh, if these developmental milestones, if not normal, then what it would be? If not normal, why not what it would be? In that case, it would be abnormal, definitely. But other than that, what do you think? Cerebral palsy. I mean, what we afraid of is a cerebral palsy. Okay, that's the thing. Okay, someone asked, why not? Okay, see, the answer you'll find here. Orthotics will consider the evidence of gait abnormalities. Is it clear, my dear? are food deformities, which are not prescribed in this case. Is it clear now? So orthotics is not the thing. Nothing for physiotherapy either, I guess, Yeah. Reassuring is fine. I mean, that's how, milestones are fine actually. So you don't need anything, to be honest. Okay. Great. Kids do fall all the time actually, so don't worry about that. Okay. Patient diagnosed with a benign prostatic hyperplasia underwent catheterization. Subsequently, the patient develops fever with chill and the rigor. What is the next step in the management? Yeah, someone said last question actually was the easy question. If some questions you want to make it complex, you can think in complex way. But previous question was easy. All developmental milestone normal, go for the answer. It's a normal development. So normal development, abnormal development, cerebral palsy. There's three conditions actually. Okay, next. Now here is the thing. Next appropriate. So this benign prostatic hyperplasia develops fever and chill. What do you think? Now this can be a complex question. Someone said change catheter, someone said blood culture, someone said B, broad spectrum antibiotic. Let's go for final. Hmm. Now why I'm thinking this question as a B. Okay. Tell me one thing. Benign prostatic hyperplasia patients are prone to develop what? Fill in the gaps. Benign prostatic hyperplasia, there's a mass, there's a growth, which is started obstructing the urine a bit, which leads to a condition called UTI often. Retention comes a little later, my dear. Retention a little later, actually. It's not the typical retention. We call it urine stasis, isn't it? Retention is a big term. I think the urine stasis, that's the term. All right. So then in urine stasis, urine is not clearing properly. There's a more chances of stagnant urine leading to UTI. So that's one of the reason fever and chill is developing, right? You must be knowing in UTI cases, without any further delay, you have to start antibiotic. Correct, guys? UTI cases, without any further delay, always start the antibiotic. That's the first thing about the UTI. Otherwise, what will happen? Otherwise, sepsis can happen. Never take any chance with UTI patients. I have seen patients dying because of sepsis. Hmm, that's the thing. Yeah, you can also do urine culture, definitely. I mean, probably more appropriate in this case. Okay, a picture of a back of a neck of a child with a honey crusted lesion, most appropriate management. What do you think? It's the right answer. Honey crusted lesion. Now you have to give me a diagnosis based on this picture. I'm going to show my face again. I have a feeling like some started feeling drowsy. Okay. So this is a proof that I'm also not sleeping. Okay. All right. So this is a condition called impetigo. So this is called impetigo. And your treatment is very specific, mupirocin. Tell me one thing, is this a treatment is bacterial or is this treatment is viral? What do you think? This is treatment is bacterial, this is bacterial. So that's why mupirocin. Clear? So most appropriate for impetigo. A quick question, is it a contagious disease? Answer is it's a very much contagious disease, right? So children going to the school, contact sports like rugby, American football, this is very contagious and honey crusted lesion actually, right? Moving to the next one. All right. I hope you are done with my face. So those of you who are still trying to sleep, please come back, sit, and start seeing the question. Okay. A 30 years male patient with a picture of penis we cannot bring the genital picture. There can be restrictions by Zoom, Facebook, and this thing. Erythematous nodule patient reports itchiness, similar lesion and itchiness also present in the groin and the hands. You can see. What is the likely diagnosis? 10 seconds. 5 seconds. Some of you are not answering. Those answering more, they pass more MC exam. Okay, final answer time. We think this is a case related to scabies. Multiple erythematous nodule. Did I say ulcer in this case at least one time? Did I use the word ulcer at any time? No, right? No. If it is an ulcer, which one of the following can be a diagnosis? One, this one, these things. So the herpes, yeah, and even syphilis. Syphilis is mostly we call painful, yeah, painless chancroid, painless chancroid. And herpes is a painful one actually, and it's mostly ulcer. That's the thing. So they said nodule. So always keep it in mind, like a genital area, few very specific diseases, very specific ones. This is scabies ones. And they also mentioned the itchiness. Is it a common thing for syphilis? Itchiness? Not really, right? It's not a very common thing. Itchiness also in the groin and also in the hands. So genital and hands together is a more possibility that scabies can be the condition. Scabies can be the condition. All right. So multiple erythematous nodule, intense itchiness, groin, hands, and in the genital, and highly sensitive with scabies. Now, can you tell me one thing? This is a very popular question. Is the treatment? It's a 5%. What is it? Permethrin cream. Now tell me, if permethrin cream is given and patient again came to you and telling, doctor, the treatment you gave is not working. Very much possible. What to do in this case? Answer, repeat the permethrin. Lot of repetition of the treatment is common in MC. We found already one earlier. I was explaining ZRD20, okay, go repeat or double the dose. These are quite common actually. So, example, you're giving salbutamol and not working. You can double up the dose or maybe repeat the dose. Yeah, many conditions like atropine poisoning. Yes, yeah, OPC poisoning. We give atropine till atropinization. So there's many similar condition. We call it compare contrast. While remembering things, you compare contrast, which is very, very important. Well done, my dear doctors. Next question. Breastfeeding baby with a poor weight gain, mother notices the child gets exhausted while feeding, taking frequent breaks, and there is diaphoresis, no changes in the skin color observed, there is no murmur. What is the diagnosis? What is the diagnosis? So it's a diagnostic question. What do you think? Many going for the answer, ventricular septal defect. Keep going. Probably many thinking ventricular septal defect because it is quite a common and it is a acyanotic heart disease. We don't have a cyanosis here, right? So many are going for the answer as a C as well. Let's come with the answer. Oh, we have chosen B. Sometimes we call it bamboo. Uh, some cases, you're thinking something else and it came out like that actually. So bamboo in our country, we call it bash, you know. So sometimes I just use that word actually, bamboo. So what you were thinking turned out to be something. Okay, let's explain with that one. I mean, it's a very close one. Okay. First of all, let's go by exclusion method. Can it be tetralogy of Fallot? Quick question. Can it be tetralogy of Fallot? It's a cyanotic heart disease. It cannot be. Anyway, it cannot be. That's out. Cardiomyopathy. They didn't mention about the echo finding, like a large chamber, narrow chamber, hypertension, too much. Nothing really mentioned like that. Or African country. Nothing really mentioned. That's out. Coming to the PDA. Does PDA is associated with a specific powerful murmur, machinery murmur? That's out. Now two things remain, VSD, ASD. Which one of them is more common? VSD is more common. On the basis of that one, you can answer it as a VSD because VSD is the most commonest. Now, is a VSD is a condition which is common with a murmur? Answer is a yes. VSD has a hollow systolic murmur, very common. VSD has a very common hollow systolic murmur. Heart failure may not be always the feature. I mean, see, VSD can be a lot of type. Isolated VSD, then small VSD, large VSD. There are many pattern gradings of VSD. Okay, that's like the thing. Now, mostly the VSD question comes with a hollow systolic murmur actually. Yeah, so that's the thing. The large one can be an answer. I won't deny, and I need echo for that. And now I need echo for that actually to go for the final. Actually, to be honest, it can be large VSD. I won't deny actually. But see, I mean, if I have to go so much typing and this that, but if you think about the ASD one, ASD is not a commonly given with a murmur. Is it correct? In the exam question, ASD is not the condition. It's not as a popular at VSD to give as a murmur condition actually. All right. So that's the thing. So ASD also is a condition which abnormal opening in the septum. I mean, I wish we have the echo here with us actually. So they might give you poor weight gain. Some cases feeding is affected. Yeah. So murmur is also can be present here actually, and it's also can be non. I mean, yeah. So yeah, cardiomyopathy, my dear. See, it's more like a chamber size, like a dilated chamber or a narrow chamber, cardiomyopathy, or systematic disease. There's like a lot of systematic disease. If you read about cardiomyopathy, they will be mentioning one line associated with this disease, associated with that disease, which is very common with cardiomyopathy. Or someone from the African ethnicity develop cardiomyopathy. Uh, or if it's a hypertrophic cardiomyopathy, that's another different feature associated with dizziness. Nothing mentioned about the dizzy and this, that here. So I think that's, I guess, out actually. So this one is quite a close between VSD and ASD because VSD is often given with a holosystolic murmur. That's why I didn't pick up. I mean, there's no other reason. Personally, I also need the echo finding to call it uh, VSD or ASD. Otherwise, if you have answered C, you are also technically correct. If you have answered E, you are also technically correct. Both of them are acyanotic heart disease, actually. All right. So that's the thing. So I have picked up ASD, but I would recommend you to go to the main exam and see if there is any other additional feature. Maybe what I can do after class, I can upload a chart for you, the differentiating points for VSD, ASD, and PDA. All of them are acyanotic heart disease, but what are the other technical differentiating point? Okay, so I will post that one. I'm sure in the main exam, they will give you at least nearby clue to that. Okay, rather than what is the answer, I think if we just prepare from our side, we can tackle the question in the main exam. This is a note. If you go to our SMA note, this is how it looks like in the SMA note. So a lot of congenital heart disease given. So cyanotic ones we know as a 5 what? 5T. Can you mention them? Two of them are very popular. Tetralogy of Fallot and another one is a TGA-TA, right? Total anomalous pulmonary. There's another one, truncus arteriosus as you mentioned. So yeah, TAPPVR. Yes, that's another TAPPVR. Yeah. So there's many actually. So you mostly have to remember this two, which comes because in exam, right? So those comes in exam. I have extracted them and put it here. Now, I have found seen VST coming. I've seen tetralogy fallus coming. Now, in case of acyanotic heart disease, think three condition: VST, AST, PDA. Correct? Everyone agreed? Acyanotic newborn holosystolic murmur. I mean, it's very popular in exam as a holosystolic murmur. That's why I didn't pick up the VST. Later, there is a breathlessness. Diagnosis, VST. Innocent murmur, 1 year kid brought to the GP what to do. The GP knows already this is innocent murmur. Now, are you going for a reassurance or still you want to refer? That's a very popular question, I'm telling it. So still you refer. The GP does not have, the GP should not actually um, give the final judgment. If there is a murmur always should refer. Another cyanotic heart disease may come. 6 weeks kid, 6 week murmur cyanotic and special spell. We call it heel knee position. Sometimes heel knee position, like a defensive position. So this is a tetralogy of Fallot. So this one is a tetralogy of Fallot. Often the 6 weeks it's given. So see, it's often given 6 weeks, not like in the first week. Have you noticed that? So 1 month or 6 week or 2 months, this is how tetralogy of Fallot will be given. Now, if the same question, cyanotic heart disease and very serious condition, vital, not okay, not okay, cyanotic, respiratory difficulty, vital deteriorating. This is what? This is TGA. Now, what happens in TGA? Now, there is a pulmonary trunk, and this is aorta. This is how the normal heart is. If the aorta switch over here, and from the right ventricle aorta is sending all the blood to the periphery, imagine how dangerous is the condition. No blood is going for purification because from the aorta directly going into the periphery, right? So this is called transposition of the great artery. Question is, does the baby survive? All bloods are going according to definition of cyanosis. Deoxygenated blood in the periphery called cyanosis. Now here, all deoxygenated blood in the periphery. So it's like 100% cyanosis. I mean, I'm just using the word. The baby will die. I mean, within few hours or within a day, the baby will die. But TGA baby can survive for few more days if there is a technical difficulty. If this is technical problem, if they have other defects, so there will be some exchange. If there is a defect, if there will be some exchange. So if associated with ASD and VSD, there'll be at least little mixing of blood. They might survive for few more days. Okay. So one more day survival in TGA if TGA, VSD, ASD together. Okay. Quick question. Is it possible that a cyanotic heart disease like a VSD can also have cyanosis? Is that possible? Answer is a yes. It is called shunt reversal, like a Eisenmenger syndrome. Eisenmenger. Now, with a machinery murmur, I saw a question in past. Machinery murmur, newborn diagnosis, patent ductus arteriosus. They are asking for what is the next step of management. The answer was indomethacin. Initial one of the management is a indomethacin or NSAIDs, whatever is given. There's another question was given, boot-shaped heart. Have you ever heard about this term? Boot-shaped heart and cyanosis. Answer, tetralogy of Fallot. So initially, PGE2 can be given to close those gaps. In most cases, it's required surgery. You must be heard about hole in the heart, right? I mean, even we were not doctor in early days when we were kids, we used to heard, oh, that boy or that girl is to have a hole in the heart. That's how we remember. So that hole in the heart is nothing but a tetralogy of Fallot. Last but not the least, if the Turner syndrome, high blood pressure, unequal BP, it can be coarctation of the aorta, another is cyanotic. And there's another condition can be left hypoplastic heart disease with a no murmur in the beginning, much less severe than TGA and tetralogy of Fallot. So this is how most of the your theoretical things can come. This is a maximum thing can come in regarding the pediatric congenital problem. Is it clear, everyone? So from this question, from where we came up, from this question, we just came up. So this is a maximal possible. So this time I feel it can be ASD because none of them were matching to though that slide. None of them were matching to this actually. So that's why I picked up ASD. But I believe in main exam, they will give you some more points. I'll try to upload a special slide for you actually after class. Okay, great. Moving forward to next one. Patient presents with the symptoms suggestive of immune thrombocytopenia, ITP. Most appropriate investigation. Come on, guys. It's an easy peasy one. Unless you make it complicated, that's on you. Quick question. 5 more seconds. Answer. Quick answer is a platelet count. It's a thrombo. When say thrombo, it's platelet. So platelet count. Okay, so idiopathic thrombocytopenic purpura for characterized by low platelet count due to immune-mediated destruction of platelet. Appropriate investigation would be doing a platelet count. I hope we don't have to worry much. Now, some cases they might mix up some questions with a ITP, hemolytic uremic syndrome. So here is a table of differentiation. Okay. This is a MC checklist. If someone wants a screenshot, you can. Make sure you don't share it to any forums because it's has some copyright things with the logo and this, that. Yeah. So if you can follow that one, if you can take a printout of that one, you certainly follow all the rules and this, that, it's quite sure you will pass the exam actually. Yeah, some cases accident can happen. Aeroplane is flying, aeroplane do crash. Whether aeroplane is the safest vehicle in the world, right? So you have to be very perfect for MC exam. So keep doing, working hard, keep discussing in different forum. Many people, I found they follow theory, recall, question bank notes, but keep doing solo study. I found them fail sometime in spite good study, good preparation. No, not whole John Murtagh, my dear. John Murtagh is specific study, specific. I mean, to the point study. Yeah, we have also theory courses for that, and I believe those of you coming to this recall course already have some preparation by own study, solo study. Yeah, yeah. But if you're starting in the beginning, so you probably recall batch may not be the best batch. If you're starting or never studied John Murtagh, recall batch may not be the best choice for you in that case. Okay, I hope you got it. Yes, it's just a standard we set. I've been experienced, so good luck. Right. Next question. Neonatal jaundice after 48 hours. Yeah, make sure, I mean, one more thing, make sure even if you're following our courses, you also, whatever the question bank we have given to you, you still follow them. I mean, I think if you're following the course, hope you must be knowing that we give idea about all actually. Okay, we have more time to talk about those actually. It's first class. Neonatal jaundice after 48 hours of birth. Please note this is a class for our recall batch starting. Okay, so if anyone from the regular, um, the suggestions can be a little different sometimes. Okay, neonatal jaundice after 48 years of birth. What is the code? This was a bit tricky question. I mean, some of us thought it's a breast milk jaundice. I mean, the ideal would be in this case is a physiological jaundice actually. Okay, so ideal term is a physiological jaundice actually. We have choose this one as a breast milk uh, technically, but right term actually we mean by physiological. Now, while having some discussion in the forum, some people also claim that immature liver technically also under the term physiological jaundice. Okay, so this is not, because this is for the first day, so that's out of the option. So it's between B and the C, that's the confusion. I mean, one thing that is for sure, we are looking forward to the physiological jaundice, the main physiological jaundice. Now, technically, immature liver immature, and that's why the jaundice develops. So, in that sense, B is also okay as an answer. So, even if you answer this on B, it's not a wrong answer; it's a correct answer. Uh, in main exam, if they mention physiological jaundice, then there will be no doubt. They'll be 100% sure your answer. But this is the trick. This MC examiner, they keep changing the option. Yeah, that's the thing. Yeah, little controversial. So that's why the reason. I mean, here is the thing. If we talk about the physiological jaundice, occurs between 3 to 5. So it means after 48 hours, it's benign, increase indirect bilirubin, raised up to 9 gram and then fall. 50% units during the first week of the life. Okay. And here is the term relative deficiency in the immature liver. Did you find this line now? Relative deficiency in glucuronidase toxin in the immature liver. All good? So probably this is the line I think probably we are missing. Yeah, it's not a diagnosis, but somewhere that's how MC do it actually. I mean, they will not give you all the straightforward things actually. So perhaps this one's answer rather than C, I think B is a better. Would you agree, guys? I think last time I think I missed that line, I think. That relative deficiency of glucuronal transfer in the immature liver. So they didn't mention directly as a physiological jaundice, but immature liver in the form of physiological jaundice. Yes. Yeah, breast milk jaundice can also occur late. It's a possibility. So let's go for B with this answer, my dear doctors. Yes, immature liver fits better here. All right. It was tricky, but we found it, right? Great. ECG shows SVT. What is the appropriate next step in the management? Another tricky question can be, let me show you the ECG. This is how ECG questions are given. They'll give you a clinical scenario and they'll give you. So this is a SVT, narrow complex QRS, narrow QRS. If it's a narrow QRS, then what do you think? Which one would be better? Valsalva maneuver. Quick question. Are we going for carotid massage for kids for SVT? Are we going for carotid massage for, yeah, that's the thing. Let me tell you, someone asked a nice question. Is this patient is hemodynamically stable or not? It's a recall question. I expect original question. Now, let me show you an original question. Okay, is it okay? Let me show you an original question, how it looks like. Okay, just give me a second. Mhm. In original question, they will be definitely telling you hemodynamic things. Now, please see this question. Give your opinion. 35-year male placed to the room, shortness of breath, dizzy, cannot stop his heart from pounding means palpitation. No other medical problem denies these problems. Blood pressure, pulse, respiratory. ECG, same as before. So what do you think? So this is original, vitals are given. Original questions, vitals are given. Answer is here, is a B, paroxysmal supraventricular tachycardia. Clear? Now, as an understanding purpose, how we can differentiate why it is SVT, why not it is VT, right? Or why not ventricular fibrillation, correct? We could have think something else as well. Now, if you can see, it is below 50, first of all, narrow complex QRS, no medical problem pre-existing. Now, ventricular fibrillation often have pre-existing medical problem. Ventricular fibrillation, often they're having pre-existing medical problem. Also, often age is over 50. Often. I have seen, is my observation, in exam, SVT is many times given over 200. I have seen what I've seen in MC exam. Whereas in the ventricular fibrillation cases, it is given below 200. SVT is quite a high. Yeah, that's the thing. Yeah, right. So in this case, this is the answer. Now moving to the original. Let's just to add what we got so far. Let me just correct it. Yeah, someone asked a very nice question actually. So why not carotid massage? Because this one I take it as a class on the day one when exam was going on. Okay, so later I get to know from the candidates it was a child's case actually, a child. Okay, so this is the update. So this class I already took it for my exam candidates of the April actually. Okay, clear now? Sorry about that. So we keep updating things actually. Sorry about that. That's why, I'm kind of like directly taking you this one to the child's case, actually. All right. So not going for carotid massage. So Valsalva here. I hope you must be knowing um, there's a summary chart, very nice summary chart to follow the John Baba. So this is a summary chart. You don't have to take a screenshot. I think you have it. I hope so. You all have John Murthy. Now, if we highlight the arrhythmic areas, SVT, so carotid massage, Valsalva, these are given. So initially, we can try that actually. Yeah. So carotid massage. If you see, this is the first line, carotid massage. The book name is John Murthy here. Okay. The second line of management is adenosine. Adenosine is not always a first line. Depends on many aspects. Cardiology is a big field. So you try to follow this chart would be more better. To be honest, if you're working in a cardiology field or if you're worked in cardiology field, that's how it does not work. Like it's always carotid massage in the beginning. That's how it doesn't work. It depends on hemodynamic stability, many aspects. And for the exam purpose, we just have to answer many of the things as per the books or as per the first line. Otherwise, it will be difficult to, you know, answer in the main exam. I hope it's clear. Let's move forward to the question. Moving to the next question. Okay, sometimes you will see, age is missing, one, two things are missing because they are recalls. A man presents with a central chest pain, keyword, ECG given on admission, patient is stable. So it's a stable patient, it's saturation 99. What's next? Now I will highlight this ECG in front of you to understand what is this condition is about. 10 seconds to read this ECG. My dear doctors, after the session, I'll open an inquiry zone, okay, in our group. So if some of your question I'm missing, I'll be answering that one. Okay, don't worry. So you can write down your question because it's, sometimes too many questions. If I'm missing, so you can ask that one in that inquiry zone after the session. I mean, in the group, we'll make one. I'll be answering all of your answers. Okay. None of your inquiry will go missing. Great. Now, here is the thing. What's next? What's next? Now, this is a pericarditis. Well done, guys. This is a pericarditis. Now, if it's a pericarditis, what do you think? What we should go for? We should go forward towards, yes, indomethacin. NSAIDs, indomethacin, specific for, yeah. So this is a ECG base. It was the diagnosis. Now, this ECG, is it a reciprocal ST elevation or is that a diffuse ST elevation? One in a V4, one in, yeah, one in a two lead to one is here. It's a diffuse, not a reciprocal. Okay, that's the thing. Indomethacin. Well done, guys. Well done. Guys, I recommend you to also read a very important thing, which is name is post MI complications. I'll teach you some other day. I mean, if I start teaching too many theoretical all the time, the class might be too long some cases, but we have a lot of time in the recall batch. Don't worry. It's a very, very important slide actually, that post MI complication. Okay. So a lot of conditions, it's like a 8-9 condition can happen after MI according to day, according to many things. I'll tell you that in future. Okay. Coming to next one. Patient had a severe chest pain on admission, no chest pain, vital is normal, troponin is negative. ECG given and normal. What's next? Come on, guys. 10 seconds. After question 20, we'll give you a break. Now, I just mentioned a similar question like that, right? So initially it can be normal. Your ECG and troponin can be normal. Still it can be MI. So you need to repeat the ECG and the troponin is perhaps all right. So repeating the ECG and the troponin, best possible answer. They can ask you in between ECG and troponin, which one is even more specific? The answer would be troponin would be more specific according to Australian guidelines. A diagnosed patient with osteoporosis, please note, it's osteoporosis, currently on resindone, which is also a bisphosphonate, presents with a vertebral fracture. What is the next appropriate step to prevent future fracture? Lot of things will come about osteoporosis in future. I'll brief you, don't worry about osteoporosis. Like there's like a 7, 8 different type of question comes from osteoporosis all the time. Now, coming to this one here, the final answer is this. Some of you are going with a zoledronic acid. Now, someday I will teach you the osteoporosis relevant these 7, 8 things you need to know. Now, see, most commonly for osteoporosis or severe osteoporosis, which is beyond minus 2.5, the treatment would be like alendronate, which is also known as bisphosphonate. Now, if osteoporosis and GIT problem or ulcer problem, what is your answer in that case? Your answer in that case would be zoledronic acid. Sorry, your answer in that case would be zoledronic acid. Now, is there anyone mentioning something like that, like a ulcer problem, bleeding, GIT problem, nothing like that? So it's probably not that one we're looking for. So perhaps B is out from here. This one is a treatment for not osteoporosis. This is a treatment for D is a treatment for osteopenia. Are we clear? D is a treatment for osteopenia. Clear? All right. Increased rosindronate won't help always here. Yeah. So rather than initiate teriparatide, new and good. So that will be better in this case, actually. That'll be better in this case. Osteoporosis related, a lot of things to talk about. In future, we'll talk, don't worry. Someone asked a question that osteoporosis and breast cancer, this is one of those 8 or 9 conditions. So if the same thing, osteo, poro, plus previous breast cancer history. Now, what is the choice? Answer would be tamoxifen or raloxifene. They can also complicate the question asking, giving both in the option. In that case, between tamoxi and raloxi, your answer would be tamoxi. Okay. Yeah, you need to confirm these things from me. Okay, which one to answer in the mini exam. Oh, well done. All right. Yeah, so the explanations given. I think I make it easy for you already. All right. Next one. Patients, after one more question, we're going for a break. Patient presents with a transient attack, which of the second episode experience with the last few years. What is the next appropriate step in the management? Quick answer, please. Yeah, my voice is also breaking now. So it's a TIA, it's a type of stroke. And in that case, what to do? I think it's an easy answer. It's a duplex. Guys, did you study our carotid end arterectomy note? It's a very nice note given. Carotid. If you go to our note section, let me just show you. I mean, not going to teach that one, but just showing it. Carotid endarterectomy. Greek note. Yeah. This is also SMA note. Medicine, neurology, carotid endarterectomy. So this is how a note is given. You can see that. All right. Yeah. Must check that one. Very relevant. We'll also discover many things. Please take note for now and later check it along with this question. So it's a cerebrovascular stroke incidence, and since TIA, duplex ultrasound is recommended here. It's not a difficult one, so that's why I'm not going for massive explanation. Last question before going to the break. Your wife noticed her husband exhibiting abnormal movement. Is it a complaint? I mean, is it a wife noticed her husband exhibiting abnormal movement? The complaint is coming from a wife. So, so should he take it so seriously? I mean, if you're the doctor and say if you're a male doctor, the wife is coming and complaining about the husband. The first thing, should he take it so too seriously? Okay, fun apart. So white, white base gate. Okay, now we can be serious. Okay, okay. Suggestive or Huntington disease. What is the next appropriate step in this case? After the session, we'll have inquiries on, my dear. I mean, if any inquiry from previous question, we'll be answering that. Okay, I'll open it in our batch, recall batch group. All right, no problem. Okay, talking about Huntington's disease, if we talk about Huntington's disease, you must be knowing this is relevant to genetic testing. Very specific. For some particular disease, genetic testing is very, very important and mandatory. Okay, so if you see here, Huntington's disease, autosomal dominant. I think most of you must be knowing Huntington's, and it is related to abnormal movement, choreoform movement. It's like they're like dancing. So behavioral change and also movement change. This is how we remember. Can often be made clinically. CT-MRI shows some finding degeneration, but the most accurate test is a genetic testing. Clear now? With evidence, references, things are given. Okay, so not going for this one, but we are certainly going for a break here. Are you ready for a break? Yes. Oh, yes. I think we have a 1 hour left, I guess, because some time went to demonstrate actually. Yes. Sorry about being a little longer today. Yes. All right. Great, guys. So thank you for attention. We'll go for a 10-minute breaks. After 10 minutes, we'll be come back and we'll be starting from there. All good? Taking off the screen, maybe. There. We'll be back in 10 minutes. All right, everyone. So please comment in the comment section if you are ready and available to start. Okay, great. Okay, so question number 20 was the last question. Let's go for quick 5 more questions to cover up the time. For demonstration, we had to spend some more time. Okay, quick question. A farmer, let's say the farmer of like 40 years farmers working in a farm, sheep presents with abdominal symptoms. CT reveals um, findings suggestive of a diagnosis based on, okay, very limited. Uh, Let me tell you, maybe a ring shaped lesion. Keyword would be sheep farming and CT showing finding like a ring type of lesion in the hepatic area. Okay, so if ring shaped lesion in the hepatic area, so it's a more probability of having a diagnosis a hydatid cyst. Okay, sheep farm is a key word. Another reason for diagnosing that, did you know for hydatid cyst, it is caused by which microorganism actually? So echinococcus, if you remember echinococcus. Now, if you remember the uh, parasitology book, what was the definitive host for this condition? If anyone remembers, sheep, dog. Yeah. Now, understand one thing: in a sheep farm, there's also a lot of dogs available. It's very common to have dogs because when there's a large group of sheep, the dogs also involved there actually to, I mean, shout towards the ships so that they came back at time. Okay, so it can be common the hydatid cyst in that case. Another interesting thing about the hydatid cyst, um, let me show you something about hydatid cyst. Just a second. Yeah, this is a John Murtagh line I'm going to show you. Yes, this is how it's given in John Murtagh. So the keyword was sheep farming. Hydatid cyst in liver, lung can be common. What you have to do is a serological test and ultrasound, surgical removal of a cyst, and giving a albendazole. Okay, so this is the main thing. Now here is the thing: hydatid cyst, sheep farming, a serological test, the same thing. I remember from Davidson medicine, I learned about the treatment of hydatid cyst. The cyst of this hydatid cyst are very toxic, correct? So what you have to do, puncture, aspiration, injection, and reaspiration. So in short, we have to remember as a pair. I mean, this mnemonic, I think it was given in Davidson medicine. Pair. If you remember the injection, this injection is given as albendazole injection. Okay. So this is the management for hydatid cyst. Management for hydatid cyst. Moving to the next question, quick and another one. Young female with a history of cocaine use. Now, guys, I'm seeing that substance abuse, one question is quite 100% in the main exam. And in these countries, the cannabis, the cocaine, these are very common actually. Either the cannabis or the more high tech is the cocaine. Alcohol is always common in those countries. History of cocaine presence in a seizure attack, diagnosis intracerebral hemorrhage. Now, it can be related. Cocaine can lead to hypertension, which is a very common thing for cocaine. What could be the likely cause of cerebral hemorrhage? So, your answer, please. 5 seconds more. So mostly I can see the answers are coming between A and E. All right. Did we find anything like a subarachnoid hemorrhage or these hemorrhagic things related to aortic, anything related to aneurysm? Mostly aneurysm rather is a more popular, um, would be somewhere related to polycystic kidney disease, actually. The kidney with more cyst, um, yeah, or family histories, things like that. Here, uh, the point we have is a cocaine user. Cocaine user can relate it to, uh, they use cocaine, and hypertension is a common thing. If you develop hypertension, and because they keep taking cocaine, there's a more hypertension, so more chances of intracerebral hemorrhage. So that hypertension encephalopathy, we mean to say, uncontrolled hypertension, correct? So that's my correlation. It's not like a aneurysm. The aneurysm thing can be family, polycystic kidney disease, okay, previous history of aneurysm. Those were the more bigger risk actually in that case. All right, right. So that's the final answer. Now, please read this question and answer. Yes, a bit is a possibility in complexity can happen in this question. 35 years with emergency department, road traffic accident, chest impacted on steering wheel, trachea noted to be centrally placed, and the distended neck vein. Now, another keyword um, is a distended neck vein here actually. Can it be rib fracture or pulmonary contusion? Now, that can be another question. It's a less likely. So, distended neck vein, you know, so perhaps what we are looking forward, we need saturation, because even pulmonary embolism some cases can be also a DD, like this pulmonary condition you have. So you need saturation, vitals, and also some of the other chest findings. Okay, a bit incomplete question, I totally agreed. And yeah, also you can see the trachea is given centrally placed. Okay, so if it's a tension pneumothorax, depends on what type of tension pneumothorax actually. Let's assume the tension pneumothorax is a big one, the massive tension pneumothorax. It's often possible the trachea will be shifted. So this is another reason we are not going for the pneumothorax. It is clear, everyone. This is another reason that in a pneumothorax cases, we expect it's not always it will be shifting, but let's assume the trachea would be shifted. So that's why you're not going for the B. That's why it is an A. I'm 100% sure in this question, your vital would be given in the main exam. I'm 100% sure about that. All right. So here is the thing. So cardiac tamponade, and we'll be trying to following the Brexer, including distended neck vein and expecting also hemodynamic instability, which is missing in this question. So we have that option, distended neck vein and hemodynamic instability, and it does not cause tracheal deviation as well. Okay, rather that would be also centrally placed. Okay, so you're using a little bit exclusion method. All good, guys. Moving to the next one. Moving to the Next one. Few more other points can be given regarding blood pressure. Um, if they give you more extended finding like a muffled heart sound like the Beck's triad, it would be nice. What is intention pneumothorax? The breath sound would be affected. So we also need the chest finding, like the breath sound. Like whatever I have seen, 90 to 95% questions in MC with pneumothorax is always mentioned the breath sound at least. Without the breath sound, very difficult to tell that it's a pneumothorax or not. Without an X-ray, very difficult to tell pneumothorax or not. Clear? Great. Next quick question. Patient coming for age is missing, presence with a routine. I mean, please understand in original exam there will be age given. Because it's recall, try to bring the one that is the raw one. The patient presents with a routine health checkup. Fasting blood sugar is found to be increased. Hemoglobin A1C is normal. Patient is asymptomatic. Next step in the management. This is a little controversial question actually. Now, one you can refer. Then this is repeat hemoglobin A1C, perform an OGTT. Now I'll go for the answer. You may not like the answer, some of you. I have my own explanation for that actually. Okay, because a little bit few information are missing. Original exam question would be 5-6 line. That time I can tell you more clearly. But let me have an explanation first actually. Okay, the question is repeating to hemoglobin A1C in 3 months. Um, refer to endocrinologist is a wrong answer here. That's for sure. It's not up to that level. So main question, it can be between B and E. E is also quite a relevant actually. So I'm just going to explain that one. All right. Um, let's see and find it out. I mean, why we're going for hemoglobin A1C? Because we don't have a satisfactory finding. So that's why in future we're going for hemoglobin A1C. Now question is, why not going for glucose tolerances is not indicated at this stage because the patient is asymptomatic. Now let's come and see why we think the patient is asymptomatic. The patient presents routine health checkup. Now question is, OGTT, you are trying to rule out diabetes mellitus. Those are symptomatic patients. Like what? Like polyuria, polydipsia, weight loss. Do you have those findings? It came for a routine check and maybe you find fasting blood glucose to be little increased. I can also tell you very practically when in case of my father, this thing one time for routine check, this thing came, they never also performed like OGTT as well. I mean, that's like, I mean, it just sounds like OGTTs, but do we always go for OGTT directly like that without symptoms? Is it okay? We'll monitor you, we'll see what's going on and this, that. So that's one of the things. Rather more focusing on the hemoglobin A1C, checking the last 3 months glycemic status is more important, you know. So those are the patient is asymptomatic, very clearly explained. And that is one of the reason the E is out. Okay. Tricky question. I hope so, guys. So that's a bit tricky question. The same question, I'm just assuming if it given as a symptomatic, those symptom I just mentioned like this, then your answer would be E. Clear, everyone? Is it clear? So if it's a symptomatic cases, we'll go for the E, rule it out. I think quite a short diabetes is like nothing present, came for a routine health checkup. FBS rate can be stress. It can be many things, right? Because of infection is stress. Tell me the secondary many causes of raised blood glucose level. There can be many reasons, right? So we'll be focusing more on the hemoglobin A1C before commenting on the patients that you are diabetic. Okay, very tricky, very tricky question is this one. All right. Next one. Okay, pregnant woman's glucose level showing abnormal value. What's the next appropriate? What do you think, guys? Now, this is the pregnant lady with the OGTT results showing abnormal value. So probably a symptomatic patient. Let's make this question correct. Perhaps a symptomatic patient whose OGTT showing abnormal value. That's how the question should be. Now what you're going to do next? You have 5 options. Um, please read there is a term called false positive causes of OGTT. Okay. And during pregnancy, many things can happen like that. You should understand which state is that. It's a pregnancy state. So here is a line. This is crucial to confirm the diagnosis with repeating accuracy, especially in pregnancy system. So you need to avoid transient hyperglycemia. That's the thing. Strains or recent dietary intake is the thing. And pregnancy is a condition where this kind of changes can happen very often. This can happen very often. All right. So repeat the OGTT in few weeks, maybe after a month. Most cases of this kind of hormonal thing usually test after a month or something like that. All right. Great. This is how the MC questions are. Most cases you'll find it tricky and many things. Yes. The patient presents with a clinical feature suggestive of hypothyroidism, laboratory showing reduced level of T4 and low TSH. What is the likely finding? Someone asking how can be false positive in asymptomatic? My dear, infection can be a reason. No worries. All right. So coming to this question, so here we have the finding. It's like a decreased level of T4 and decreased level of TSH. So what do you think? Let me just check the question again. No, I'm just checking this question. Maybe. Let me just correct this question. Yeah. Yeah. I guess there was typing error or something like that. Now, what do you think? Okay. Now, if you see decreased T4 and high TSH. Yeah. Now, okay, right. I think it was a typing error, I guess. Yeah, I was also confused, what just has happened. Yeah. So it's primary, I guess. So, okay. I'll show you a slide actually that might um, clear some of the more views. So this chart, one particular chart is very, very useful. I often use it. Even for my own practice, I also use it a lot. Can you see it in the screen? I hope it's a yes. Now, if you can see primary hypothyroid, T3, T4 low, and TSH elevated. That's the basic, which is in our question actually. Now, there's a few more other conditions will be given and very popular in the exam. So primary, secondary, and subclinical. Primary, secondary, subclinical. Now, in the subclinical, what happens? Very popular in the exam. Normally, we differentiate hypo and hyper by the T3, T4. See the T3, T4 quickly we understand. Even though TSH is the main parameter. Now, in subclinical, the T3, T4 remains the normal. Because TSH is a major parameter, it is still elevated. And TSH elevated means original diagnosis opposite, so it is a hypothyroidism. So THS up, but T3, T4 remains normal, which is a subclinical. I hope you got it. Then the options can be there's a secondary hypothyroidism. In secondary hypothyroidism, because of secondary thing, the TSH got affected. Secondary reason, TSH, which is the main parameter, got affected. And T3, T4, as usual, it is low. So that is the secondary hypothyroidism. Secondary hypothyroidism. So this primary, uh, primary, subclinical, and secondary, you have to remember. And rest are vice versa. Rest are vice versa here. One more I want to add, which is a little bit unique and different, is some people also fake, for their job. How they do that? Like they start taking thyroxine pill and then they do the test and the test result shows that, they actually have a, you know, thyroid problem, which is often known as factitious thyroiditis. Now, what they do it is taking thyroxine pill. Now, normally, interestingly, uh, like there's a ratio between T3 and the T4, right? Ratio between T3 and the T4. Which one is number is high? I mean, so of course, like the T4 possibly. So 1 is to 30. That's the thing. Normally 1 is to 30. T4, because T3 converted into T4. So normally 1 is to 30. But in factitious, it becomes like a 1 is to 70 because the T you are giving from the outside preformed, and which is mostly T4, the converted one. So the T3, which is never raised actually. So in factitious, it is 1 is to 70, whereas in usual original, thyroid cases, it would be 1 is to 30. Everyone clear about that? So this is the last point of here actually. It's not very clearly mentioned, but I hope so it's clear now. Now 1 is to 30, usual cases, but in factitious, those are faking because taking the T4 from outside. So only T4 is raising here. All good? So this is how you can remember this primary, secondary, subclinical, primary, secondary, subclinical, and an extra one is a factitious, and vice versa. The hyperthyroid primary, hyperthyroid secondary, and subclinical. Is it clear, everyone, about this chart? Is it clear now? I mean, I explained the hypo ones, the hypers are vice versa, similar and opposite. And an extra one is a, yes, factitious. Excellent. Moving to next question. Okay, let's say, okay, 40 to 50. Let's say 45 presents with a lump in the breast. On examination, firm mobile lump is noted. Additionally, both breast feeling lumpy upon palpation. What is the likely diagnosis? Good. So fibrocystic changes in the breast. Fibrocystic changes in the breast. Well done, guys. If I ask you a few quick question about a breast lump, okay? Example, if you find um, someone like a 28 years with a breast lump, what did you suspect? 28 years. So 28 years means like a 25 to 35, right? So you'll think more about the fibroadenoma. Now, the same question if I say someone 38 years, which is like in between 35 to 45 or 35 to 50. So in that case, we call it fibrocystic breast changes. If I say someone 55 years or 65 years, which is over 50, now what do you think? In a non, it's a carcinoma. Is it clear? This basic, please remember it. Please remember it. If a breast lump in this age group, you'll think this is the first diagnosis. So we just, use that formula. Like, so it's a given 40 to 50, let's say 45. It's a fibrocystic changes. Okay, I'm just using that formula. And you must be knowing about the triple test and all these things. Next question. Patient with a milky nipple discharge and infertility reveals elevated level of prolact. What is the likely diagnosis? Prolactin high. So, and infertility, milk length. So in that case, what is the most likely cause of the diagnosis? Most likely cause of the diagnosis is a hyperprolactinemia. Hyperprolactinemia. Let me ask you a quick question. There's another question I have seen. I'm not only give you information about the current question, also how things have tested in past. With the level of prolactin, is it possible to make diagnosis between drug-induced hyperprolactinemia versus prolactin secreting cancer? Is it possible? The answer is a yes. So in drug-induced cases, the level of prolactin would be less than 4,000. Whereas in prolactin secreting cancer, it would be over 4,000. Clear, everyone? So this is another question we have seen in past, drug-induced versus prolactin secreting cancer. All good? Everyone good? Great. So this is how another way in MC question has been tested. Next question. A 35-year male, father diagnosed with colorectal, 45 years, and maternal auntie also diagnosed. So two first degree relatives. How should the individual screening for colorectal cancer? You have 5 options. I'm giving you 20 seconds for this one, as this is something to think about. If you don't complicate the answer, you can, feel like you will be able to answer it nicely. Please check the person's current age group. This is 35. All right. Right. Tricky, but if you have answered A, perhaps you're right. Because two like first degree relatives, so the person is going in a bit a high risk zone actually. Okay. I'd highly recommend you. This is one area it keep changing all the time. So I mean, say maybe your exam can be out at the month of August or even November. I highly recommend you few screening program you should always check before going to the exam. One is the colon cancer relevant. Okay, so colon cancer and type RACGP, you will find uh, the relevant link. Another one is a breast cancer, and also type RACGP. It's another screening program you will find. And last but not the least, prostate. Okay, very popular in the exam and also type RSCGP. Okay, so these three and another 7, 8 are very important. I'll tell you which one of them in coming days. So those things definitely check, you know, before going to the finals. Okay. And also, I think we have a note in our note section. You can also check it. Other references are given. And perhaps I think we will also add a bonus class for you on the screen. It's a keep changing thing. It's a keep changing thing all the time. Great. A patient with intermediate claudication, reduced ankle brachial pressure index. How should the condition be diagnosed? What is the appropriate investigation? Okay, this looks a little bit messy, this question. Take some time, take some time. Okay, it's not a difficult one. It's a easy peasy one, sorry. If you're thinking as a A, you're absolutely correct. It's not a difficult question. Sometimes there's a question size, which makes so reduced ankle pressure, intermediate claudication. Perhaps the artery has problem. You just need an ultrasound. Very simple. Your artery probably is having issue. You just need an ultrasound. Very simple question. Peripheral arterial disease, intermediate claudication, reduced ankle brachial pressure. You just need to use the ultrasound Doppler. That's the thing. Very simple. It's not a complicated one. A male patient undergoing aneurysm surveillance is a 4.8 centimeter in that artery. What is the appropriate management strategy? So this is a question related to another that abdominal mass. See, mass related another question came out. Triple A. The triple A looks nice. First of all, now what you want to do? So many, are you going for surgical repair for 4.8? Do you really want a surgical repair in 4.8, or you want to go into medical management, or you go for a surveillance? Now, some people might get confused in the word surveillance. This means surveillance means the answer is a surveillance actually. Okay. So in cases of surveillance, let me show you. It's nothing but that ultrasound and observation. Let me show you a reference. Let me show you that reference. Just give me 1 second. Yeah. So this is called actually surveillance. It's just active surveillance. So it's given 4.8. This is taken from RSCGP guideline. So you can see, so 4.8, how persistently you will do this surveillance within testing with ultrasound. So answer is a 6 monthly. Answer is a 6 monthly. You will do that surveillance. So they just tried to confuse you in this question. Correct? If they have answered 6 monthly ultrasound and the surveillance is the same thing. Is it clear now, everyone? They just flip the word to confuse you. They just change. They often do that. The MC examiner, we define the examiner in a little different way always. All right, they'll try to do that. Next, patient diagnosed with a stone in the upper pole of the kidney. Size they didn't mention, but it's very important. Patient diagnosed stone in the upper pole of the kidney. What's next step? Yeah, I think it's a missing question. I personally feel diagnosed with a, it can be anything. It depends on the size. Patient diagnosed stone in the upper pole of the kidney. Yeah, here size that something is major actually. It's an incomplete one. Now it depends on the size. I just mentioned it. I put it as a E. I mean, don't go with that one. It's just mainly you have to follow this chart. Let me show you a Reynolds stone slide. Um, just a second. Reynolds stone. I have a slide for you. Fantastic slide. Let me show it to you. Just follow this slide, guys. I mean, that's an incomplete question. Here, definitely size would be given 100%. I've seen many questions with renal stone. 99% cases is always the size is given. Yeah, that's the thing. So you follow this. The size less than 2. Some books says 2.5 as well. Some books says 2. Let's say less than 2 is a ESWL, more than 2 is a PCNL. If it's a very narrow margin, like a less than 5 millimeter, or say zero point 0.5 centimeter, zero point 0.5 centimeter or 5 millimeter, it means same. In that case, conservative treatment. Ask the patient to drink more water and this, that. Otherwise, this is the management we are following. Is it clear, everyone? I mean, how to follow the renal stone questions? This is the thing. Another question we have seen coming from the renal stone, um, it was mentioned like that. Uh, which environment is better for renal stone? I mean, what environment you will create to get rid of the renal stone. So this was it, checking your depth of knowledge. So this one might be useful for you. This chart might be useful for you in that case. Yeah. Say avoid food that are rich in oxalate. Why? Because oxalate stone is a possibility. So my question is, which media you want to create to clear the renal stone? Answer is the alkaline. Did you know, guys, there is alkaline water available nowadays? Guys, did you know nowadays alkaline water is also available? Expensive. Yeah. And drink as well. Yeah, cranberry juice, my dear, good thing. So you can see, so testing the depth of furnace. So long back, it's not a recent one which I was talking about. It was back tested. So they give a lot of scenario and which one is good for renal stone they were asking. So they were saying high oxalate food. They were selling um, high protein. High protein always not recommended. So this is an example. Someone develops renal stone. Is it also important to ask about the diet? Very important, because if the person is not following the balanced diet and too much high protein diet and taking the multivitamin probably or not, so many people, when they started too much dieting, it's not good always for the kidney, mind it actually. So even if you are in protein diet, you can take high protein, but you also have to be careful in that case, because high protein diet can be leading to, so many of you has a common practice, especially I also do gym, like for last 1 year I'm also doing, um, but um, initially I was taking some of the protein, the powders. So then another instructor, they said, even two instructor, even one in UK, one here, they said you don't need a protein powder actually, because you are not trying to do body hypertrophy or too much, heavy weight. So take the protein which is necessary. So this is a very common mistake. Some people think, okay, I'll take the protein powder and my body will grow very fast. So that's the thing. So it's very important. So make sure, unless you are really going for very heavy gym and you understand that you need protein and this, that, otherwise that protein powder is not always, otherwise that will give rise to this problem, renal stone. So many uh, bodybuilder fit, but ended up with renal stone often. Okay. And also very important is your water intake all the time. No matter how the diet is there, your number one important is your water intake. Very, very important. So many people use detox nowadays. First of all, optimum water, then comes the detox. Some people take alkaline water. So if your kidney is fit, all the toxic things will go away. Okay, very basic. Great. Sorry about taking some time for dietary advices. Okay, sorry about that. Yeah. So this question is a bit incomplete. We will follow the renal stone relevant management. Clear, everyone? Yes. But only dietitians are not always good. Like very rare that you will find a very good dietitian and who will really understand you. The best suggestion I will tell you one, you know how your body works. Okay. If you start doing exercise, you will understand what I'm saying. You know, So you actually know your body best, actually, So this dietitian can just advise you this, that. So, but you will understand once you will be in the, yeah. Okay. The man presents with abdominal pain radiates towards thigh and scrotum. Abdominal pain radiates towards thigh and scrotum. What is the likely diagnosis? So what do you think, guys? So we put it as a renal colic, high chances. If I want to correct this question a little bit, I would say 32 years. Okay. I would say other abdominal pain, I would say loin pain, radiating towards the thigh. So it's more like a ureteric colic to me. Okay. And there can be risk factors like less water intake or some of the other factors like high protein diet or too much diet. So any risk factor will be also given in the main exam. Okay. Next, guys, scrotal or testicular mass is another mass I forgot to add. Testicular mass is another very important, often comes. On examination, patient has a tender scrotum. The examiner cannot get above the lump, can't get above the swelling. This is the term. I hope so. You must have heard this thing in an MBBS, that can't get above the swelling. You heard this thing, right? There's no cough impulse. The lump is not transilluminating. Most appropriate management. Now, let me clarify that one. Some people may have gap in the study. If this is the scrotal area and you're trying to examine this part, trying to get above the swelling. So get above the swelling, get above the swelling. I mean, you try to palpate and you try to, so get out the swelling positive in cases of testicular tumor. Understood, everyone? And if there is a something that is coming from above, you try to get out the swelling, can't get above, can't get above. In that case, it would be hernia. Is it clear to everyone? In that case, it would be hernia. In that case, it is a testicular tumor. So get above the swelling, can't get above the swelling. This is can't get above the swelling. Let's coming here. Is a testicular tenderness. So we have with the tenderness, orchitis, torsion. I mean, this is out. This is probably out. And hydrocele also has transilluminating, so not transilluminating. That's also double out. Varicocele often they'll tell you left-sided, but varicocele usually not tender, non-tender varicocele usually. So that's double out. Now, epididymoorchitis, testicular torsion. They didn't give us a on examination finding in that way properly. Okay, so what do you think? Which one it can be? So final answer is a C. Because John Muttak, the first line is written. If it is a tender scrotum, it is torsion until proven otherwise. Secondly, it was mentioned can't get above the lump. So it is a testicular lump, first of all, because can't get above the swelling. Then it is mentioned tender scrotum. Until proven otherwise, very first line written, even the title is written like until proven otherwise, it is always torsion. Clear? Then we will think about that. Now, if it would have been epididymoorchitis, they will be giving you UTI-like feature or dysuria-like feature. Yeah. Yeah, I think this line is we just need to correct. Yeah, just ignore that part. Yeah, yeah. What about the most appropriate? I mean, it's a diagnostic question. Okay, sorry about that. Okay, let's ignore it. Mm. So UTI-like feature, yeah, sexually active, this, that. So there'll be more chances. All good. Orchitis cases, more chances if it's a children's case. Children cases, more chances with orchitis or mom's orchitis. They will be telling they have a flu recently and one side of the salivary thing is swelling. Then it's a more chances of orchitis or a pancreatitis history. Uh, is it possible? Pancreatitis later can be orchitis possible. Yeah, some cases. Yeah. Okay. So here is the thing. I think I already explained. Can't get above the can't get above, indicating it's a testicular, and painful means suspecting torsion. All good, great. Next, a man with osteoporosis present with a vertebral fracture. X-ray reveals sclerotic lesion. This is the key word here. Sometimes they will test your radiological knowledge as well. What is the next appropriate management? What do you think? What is the diagnosis? Osteoporosis presents with vertebral fracture. So reveal sclerotic lesion. Now, what is this sclerotic lesion can be related to? I'm giving you 10 more seconds. Okay, let's just find out. Let's see some of this question here. Um, First of all, man with osteoporosis presents with a fracture. Now, quick question. Osteoporosis leading to fracture is a common thing, first of all. So they're asking for appropriate thing. So if X-ray has been done and vertebral fracture and this, that. So I think the next possible thing you should do is a DEXA scan. Or maybe you can offer the MRIs and all this thing if there is a indication of MRI. Yeah. That's a possibility, sclerotic lesion. Um, if it's a, let's assume it's a prostate cancer. Okay. Let's assume it's a prostate cancer. Now, if it's a prostate cancer, what else? PSA is a very non-specific. Why I would do PSA here, first of all. Um, if it's a prostate cancer, what is some expected? First of all, it can remain asymptomatic, quite a possible in prostate cancer. Otherwise, weight loss, dysuria feature, and many other things would be given. Okay, many other features, DRE finding. If you search in AMC guideline group with the prostate cancer, you will find many relevant thing actually, many relevant thing. With mentioning that word, sclerotic lesion always does not mean metastatic prostate cancer. Okay, it's a big term, it's a broad term, sclerotic lesion. So many things can be under the umbrella. So since it's been already mentioned, osteoporosis, vertebral fracture. So from osteoporosis, the fracture is happening. That's how we will think first. Okay, that is one of the reason to rule out the DEXA, that if there is a one fracture, it is possible the femur can fracture later, some other places can fracture. Osteoporosis fracture can lead to death many times. So osteoporosis, severe one, is an emergency always. I repeat, there was a line in the red book. The osteoporotic thing, if there is an emergency and fracture, you would love to do, or you have to do another DEXA scan. Okay, another DEXA scan first. Actually, if you forget, let me just remind you, it's not that easy as you always thought, the MC things. Uh, just give me a second. Okay, here is that one. Now you can see this. If there's a high risk one and someone has a low trauma fracture, can you see that? Low trauma fracture. With that low trauma fracture, or here your finding is what? Your finding is your fracture. Please, guys, focus on the question. If this is the scenario, you all will be biased in the main exam. Your chief complaint is a vertebral fracture, isn't it? What is your chief complaint? Your chief complaint is a vertebral fracture. Don't forget that, guys. Okay, so the MC will bias you many times with this kind of question. When osteoporosis presents with a vertebral fracture, this is we have a very bigger thing to deal with, here. So that's this one is also can be similar, a low trauma fracture possibility. And what you have to do, DEXA and presentations after initial resuscitation. You have to DEXA. Now, why we do DEXA in these cases? This is taken from RSCGP Red Book. Why we do DEXA? The reason behind that one. Why we do DEXA here? The reason behind that one, because there can be fracture risks in other bone, like femur. How many people died because of the fractured neck femur? Many in everywhere. I also know one, two of my relatives that died because of just slept in the bathroom and, you know, fractured neck because it's the density is low. So vertebral fracture because of osteoporosis means you need to first rule out what else going on. You'll get a clue. Then if it's a prostate and this, that, you will come back to prostate. You get me, guys? I hope so. All right. So I don't have any doubt. Those questions I have that I always tell you. This one I really don't have doubt. This is your chief complaint is a vertebral fracture. I'll follow that lead actually to rule out why there's a vertebral fracture first of all, and I need to go with the uh, RSCGP method here. Well done. Moving forward. Nurse informing the patient burns in the ward with a palliative, and the nurse, what is the most appropriate action here? What do you think? An action here would be seek clarification of the patient about the concern. So D would be your answer here actually. You can see the explanation later. Don't worry. So that a patient with burn under the ward under palliative care wishes to go after a word discussion between you and the nurse. So just ask the patient. It's like an ethical question. As explanation, you can read it after the class. Don't worry. It is suspected that association, this is a question related to association between river flowing behind the community and childhood cancer incidence in the community. What type of a study is this? Again, a very straightforward question. The answer would be, is it a case control, cohort, or randomized control trial? What do you think? A case control study um, investigation attribution that exposed and outcome when outcomes are rare. So in this case, involving the individual with outcomes and without the outcomes, yeah. So that goes more with the case control study. Uh, yeah. If you want to see the effectiveness of vitamin C in a community, just for example, then it goes more with condition like randomized control trial, right? So that's the thing. If it's only discussed about association between exposure and outcome only, then it's a cohort study. All right, moving forward, we have a biostat related whole section. Those of you already joined and notes are already given. You can check the biostat video if you're having hard time with biostat, but we'll talk about biostat in coming tests, don't worry. Okay, let's just finish. I think it's getting late. You observe a junior doctor practice incubation on a diseased, I think, person. What is the most appropriate course of action? Okay, I think it's a very straightforward. Inform the doctor it's unethical to perform this person without proper authorization. It's a very straightforward. Yes. Patient asking preventing hookworm infestation while traveling. When I see the word hookworm, it reminds me someone's name. Okay. You know, what is the most appropriate advice in this case? So I think we all must be knowing, I think you all studied parasitology. So hookworm is more common in barefoot. Yeah, that's the thing. That's why nowadays we hardly need any tablets and things as like before. Yeah. All right. Next one. Patient presents with a picture like similar like this. I'll zoom this picture. Yeah. Showing malignant melanoma mentioned already. This is the size. Report having lesion long time. Now presents with itching. What is the most appropriate next? So it's a melanoma case, and they're asking you what you can do. Okay. Size, my dear doctors, it's a quite a bigger size actually. Okay, very basic. So for excisional biopsy, smaller lesions and low suspicion malignancy. I mean, say if you open the melanoma section in John Mottak, even minimal suspected lesion, we do the excisional biopsy. Very minimal suspected. Okay, like suspected biopsy or very minimal, that's excisional actually. And here's the, you can see it's a massive unit punch. All right. This is the appropriate one here actually. Okay. Patient with a, you can make a diagnosis and then can refer to the dermatologist. A GP can also send for a biopsy. It's not a big thing. Okay. That's the reason we are not going for a dermatologist at this point. All right. Let's see. Just give me a second. All right, guys. It's like I think it's been a while. Thank you for your attention, for attending the session today. I think it's been a while. The class, I hope you enjoyed overall. Yes. And yeah, let's take rest now. My throat is hurting right now. And yes. All right. Yeah. Yeah. See, question bank reference is not a reference. And those question bank came much later. I mean, and I've been also teaching even prior to those question banks actually, so they most of them they copy a lot of my questions and this that. All right. Of course I can be wrong but many things, but please make sure question bank never uses a reference. Mplux type of question bank has like a 7 to 8% of flaws, mistakes. Secondly, even Amedex has 3% of mistakes sometimes. All right. So thank you so much, guys. If you have further inquiries, drop me some of the questions. We'll get back to you in 24 hours. You can also WhatsApp me. Um, that'll be also okay. You can also, yeah, or you can leave a thing in my Facebook. That's also fine for me. Right. So that's the WhatsApp. You can text, or if you already are connected to the messenger, then you can leave a message in the messenger. After taking rest, we'll get back to you. The main thing, I hope you enjoyed. And if anyone is joined a little late, I hope so. Some few of the things you might have missed. Let me tell these things again. There'll be weekly 2 classes. This is the class timing. Try to attend live. We'll also give you the class recordings and 5 years record as well. Use a laptop headphone for a better view. This is the class routine. Yeah, we'll be following. You'll see 1 year or 1 year plus live classes, including computerized 2 big mocks, and smaller mocks will be also discussed in the next class upcoming. Yeah, so these are some of the particulars. Very tired to answer anything right now. And yes, all right. Already mentioned class requirements. Follow these tips. How tested EMC I have explained already. Thank you so much, guys, for your attention. And you can join the recall course if you want. And feel free if you have any question, drop things actually. Yes, great. Those of you join, yeah, I'll try to upload this one in my YouTube. And those of you who are in the batches, we also send those things by the drive. So it will be uploaded normally after 24 to 48 hours, most cases. Okay. So thank you so much again, guys. Good luck and good wishes. All right.